No, it's a public health issue. It can be tackled. It can be addressed. And it's a system, as I said, that is based on race, that unfairly advantages and disadvantages some individuals and communities. I now believe that it's a fundamental determinant of health because of its dynamic, multi-generational, multi-system impact, the fact that it endures over time, and the fact that it works through multiple mechanisms, right? Health policies, economic policies, the past practices and pathways that we have that generate health, that support health, are all affected by structural racism. And we now know that the health effects of living in a society where structural racism is manifest, we see its impact in a range of adverse outcomes. So not just health outcomes, but educational outcomes, criminal justice. We're having conversations now about maternal health outcomes, as if this is something new. It isn't. It is a new issue because now we're bringing to the table the impact of structural racism and saying, actually, if we are truly going to help to reduce the threefold difference in Black maternal mortality, then a key part of the discussion is thinking about structural racism and integrating that into our efforts. It is a public health issue because we now know through a range of surveys of how prevalent it is in society, and we now know the impact that it's having, as I mentioned, on many aspects of the lives of individuals and communities in our country. But the key thing is understanding that it is measurable, it is stoppable, we can intervene, and we can have an impact on it as well. Now, there are a number of studies which have helped us to understand racism in the UK, and throughout the course of the day, there'll be others who will give more contemporaneous data, more up-to-date data from the work that they're doing. I didn't want to steal their thunder presenting their work, and it's always best to hear from them. We'll hear from colleagues from NHS, from the NHS Race and Health Observatory. But let's look at some of the ways in which we're seeing racism manifest within our society. And let's go back in time to think about the seeds of the research that have informed our understanding and the work that we're doing today. Work, for example, from the Race Equality Foundation, which really confirmed nearly a decade ago that ethnic groups experience poor treatment due to negative attitudes related to their character and their abilities. And this results in everyday interactions that people have. And these interactions have a huge impact on people's physical and mental health, their opportunities within the society, their ability to take advantage of the things which generate and improve health. And it also impacts the trust and confidence that communities have within the system. In 2020, the Health Foundation further studied this, and this was in light of the unfolding data in the COVID-19 pandemic. And they argued that racial discrimination affects people's life chances negatively in many ways, restricting access to education and employment, those social determinants of health. And we know that people from Black and ethnic minority communities have poorer socioeconomic circumstances, leading to poorer health outcomes. This isn't new, but when we know better, we must do better. The Race and Health Observatory has been providing rich data as we went through the pandemic about the nature, magnitude, and impact of these health inequalities in the UK. The fact that Black women are 4 times more likely than white women to die in pregnancy or childbirth in the United Kingdom. The fact that South Asians have a 40% higher death rate from coronary heart disease than the general population. The fact that we know that Asian and Black people are 2 to 4 times more likely to develop type 2 diabetes. And we've been working and we've known these data for a long time, that Black men, Afro-Caribbean men, are up to 3 times more likely to develop prostate cancer than white men at the same age. For many of us in this room, these statistics may not be new, but when taken together and we see the scale of the differences which exist, this must be a call to action. It must be a call to activism, and it must be a call to evidence-based approaches to tackling these disparities. Now, in the pandemic, with the Beyond the Data report, we really had to be honest. And a lot of you know that, I've said this before, that without honesty and authenticity and having tough conversations, we will not get to where we need to get to, because we keep skirting around the issues. And one of the things when the report came out was people saying, well, how can structural racism affect, what is the impact that it has on poor health outcomes? Now, the report didn't go into that detail at the time, but our work subsequently has been to unpack the ways in which structural racism actually results in poor health outcomes. Number one, it affects your access barriers to healthcare, right? So it prevents your ability to access healthcare in a timely way. It results in poor trust and confidence in healthcare services. So people are not going to be using the healthcare services. And I remember in the COVID-19, when we spoke to people from Black and minority communities as part of our town hall events, and we said to them, what's preventing you from going to the hospital on time if you're worried about COVID-19? And they said, Doc, we can't call NHS 111 because we don't speak English, and we're not confident enough to navigate NHS 111. Doc, we don't want to go to the hospital because they haven't treated us well as a community before, and I have no confidence that if I go to them now, when I'm sick, I'll be treated well. Doc, I'd rather stay home with my COVID-19 than go to be treated in that nearby hospital. Some really painful stories to hear at the beginning of the pandemic. So structural racism affects access to healthcare and creates barriers to healthcare. It also creates barriers in clinical decision-making as well. And we know very well that studies have now shown that if you are a Black woman or Black man attending accident and emergency departments and in need of pain medication, you're less likely to get the pain medication that you deserve based on your clinical need compared to white patients. We know that in maternity services that decisions are made based upon race and cultural background on women's likelihood to get the appropriate pain medication, whether cesarean section is undertaken, and the degree of intervention that you will have in your pregnancy. It results in inequalities in patient outcomes. And I've already highlighted a number of areas where we see significant differences with poorer health outcomes, diagnostic delays, delays in receiving often suboptimal treatment. It results in workforce disparities as well. And coming out of the pandemic, we now understand that you cannot have a healthy community if you're not treating your workforce well. Why? Because that same workforce is coming from your local community, right? So if that workforce is facing racism, discrimination, bullying, and harassment, what do you think they say when they go home? And they speak to mom and dad, and they go to church on Sunday, or they go to the mosque. They say, actually, that institution, that place, doesn't recognize me as being human. It doesn't recognize me as being valued. And this is how you have that vicious circle of lack of trust and confidence between the community and the workforce. And finally, it results in lack of diversity in clinical trials. No one could understand when we did town hall events in the pandemic why the numbers of Black and brown people in the emerging early studies of the COVID vaccine were so few. And people would say, well, Doc, why should I have a vaccine if it's been tested in 48,000 people, but you only had 100 Black people in it? Systematic biases and racism, which structure who gets invited to clinical trials and who funds clinical trials, really came to the fore in the pandemic and meant that it had to change the way we did studies and trials in the pandemic in order to build the trust and confidence that was necessary. Now, Leonora has already spoken about the impact of COVID-19. I just want to look now, as we look 2-3 years after the pandemic, just to show the cumulative impact of those disparities on what happened in the pandemic. This is looking at the 2-year period from the beginning of the first lockdown, the 21st of March 2020, to the 14th of October 2022, and it looks at the excess deaths that occurred from COVID-19 in England. And you can see on the left-hand side of the chart the ratio of registered deaths to expected deaths in England by ethnic group. And you see the significantly higher actual deaths that occurred among Asian, Black, and mixed groups compared to white groups. So everybody had excess deaths because of COVID-19, but you can see a greater magnitude of excess deaths on the left-hand side of the chart occurring in Asian and Black groups. And the data that underpins that are on the right-hand side of the chart, which shows a summary of deaths in England by ethnic group. And you can see the significant numbers of lives that we lost through the pandemic as a result of these inequalities. And you see why in Professor Jones's definition of racism, when it saps the strength of society through lives and resources wasted and lost. This is what we mean. Now, throughout the pandemic, we learned that not only is structural racism affecting outcomes, but it manifests itself in different ways. Reports have highlighted that inequalities by race ethnicity were seen in your likelihood of becoming infected with COVID, your likelihood of being diagnosed, admitted to hospital, admitted to ICU, developing severe disease, and dying from the disease. And we began to understand the mechanisms through which this worked, right? So it's not just the color of your skin that ended up with the poor outcomes. It was a fact that people who lived in overcrowded or multi-generational households were far more likely to acquire infection and to have severe disease. People who worked in jobs with an increased risk of coming into contact with members of the public or with people who were infected with COVID, like nurses, physicians, healthcare workers, were far more likely to be infected from the disease. People who lived in poor areas were more likely to die, and people who had low engagement due to stigma, low trust, or confidence in the health service were far more likely to be diagnosed and to die from COVID-19. And of course, people's experience with historic or current experiences with racism and discrimination also had poor outcomes. So the mechanisms through which this worked were multitude. So we were able to look at various pathways through which poverty and racism influence health outcomes during the pandemic. This is a chart from one of the studies that was published at this time. Because oftentimes people say, in order to discount structural racism, is it racism or is it poverty, right? As if the two can't exist together, right? As if the two can't be true. And so some studies that we've done and that we've worked on have really looked at how you can begin to unpack the two. And the reality is that there's a very strong relationship between racial discrimination and poverty, either due to policies of the state and, of course, the economic crisis. We've come out of the pandemic into the cost of living crisis, creating labor market conditions which disproportionately affect people of color. These two factors then influence a number of things. They can result in a higher likelihood of pre-existing health conditions, which I've already mentioned, higher likelihood of heart disease, diabetes, and other conditions. I've already mentioned it reduces access to healthcare. If you're poorer or if you're experiencing structural racism, you're less likely to access healthcare. You're more likely to live in neighborhoods and in housing conditions which are poorer, which have a material impact on your health. And of course, in terms of your employment, you're much more likely to be in high-risk occupations and environments. And all of these have an impact on COVID-19. Now, since then, other studies have looked at how do you apply this pathway to understand different outcomes. And I know a number of you here are working on maternal health outcomes and trying to understand why Black women are so disproportionately affected. And that same approach in terms of understanding the pathway is important. So, for example, this is a study from the United States, which really shows that if you link in the systemic factors, for example, COVID-19, emergency policies, then you layer that onto healthcare decisions and healthcare policies. Oh, that's not my phone. Healthcare decisions and healthcare policies. And then you link that to community and neighborhood factors. In the United States, racial and residential segregation, poverty, education, and employment. Then you begin to create the ecosystem through which this occurs. So, I'm going to now move to the second and final part of the talk. I really want to begin by centering us today. So we had the definitions right. We know what we're talking about. We've understood the prevalence of this issue as a public health issue. And we also are looking at its impact and the mechanisms through which it operates. So how do we take these lessons then? Because when we know better, we're going to do better, right? So how do we take the lessons from the pandemic to fundamentally change what we're doing and how we're doing it? The first is being honest with our experience of the last 2 years and to say, what did we do differently in the pandemic that allows us to get to this point today? Well, the first is that we funded and we developed a lot of equity-focused public health programs, right? So the London Health Equity Partnership, London Inspire, the work that we've done on COVID vaccine, you name it. We realized that we couldn't get through the pandemic doing what we've always done. We funded and we resourced equity-based programs. Second, we developed a whole range of partnerships, and London Inspire is a wonderful example of this, where we said we have to break down the traditional barriers between healthcare systems and the community and co-produce, co-develop, value community input into our programs. We had data in the pandemic that allowed us to understand where the infection was spreading, where vaccines were being done, and the impact of all of that on health outcomes. And we developed a whole suite of new research activities that really helped us to understand not only why we're seeing, what differences we're seeing, but why we're seeing those differences and what we needed to do to address them. And finally, we developed a whole infrastructure of community-centered outreach, engagement, and empowerment. Many of you are in this room because you were part of that activity that helped us to get through the pandemic. We forget these lessons at our peril. And what we're now doing is understanding how we lock these into the ways in which we do business within our society. Now, this slide was going to be animated, and it isn't. So there's a lot of information there. So I'm going to take you through it because this is the core of the London approach to addressing racism in health and care systems. And it builds upon all of those lessons from the pandemic. And it challenges us to go further and to make this business as usual in the city. This has now been signed off by every ICB. We're working on provider trusts. We're working with local government institutions. We're creating a whole ecosystem in understanding racism and health, but adopting anti-racist approaches. So the framework has 5 key elements. It starts with leadership, visible leadership on racism, naming it, understanding how it operates within systems, and setting up the governance and the programs to address it. Second, it talks about the workforce, that you cannot be an anti-racist system unless you're treating your workforce well. You're tackling racism, discrimination, bullying, and harassment. You're improving your workforce race equality standard data. You have programs where you're celebrating the success and how you value diversity and inclusion. And you are clear that DEI isn't a woke part of your work, right? When you have 50 to 60% of your staff in a hospital trust in London being black and minority ethnic group, DEI isn't a nice to do, it's essential. In fact, it's good business, right? It's good business. It also includes being clear about the programs that work in an environment where we have fewer resources, things are tight, we can't do everything. So looking at evidence-informed programs that really have an impact on health equity become key. It also talks about becoming anchor institutions. Many of our hospitals employ many people from the local communities. We're commissioning, spending millions of pounds on commissioning services. Ensure that those funds are going back into local communities and supporting black and minority ethnic communities to address those social and structural determinants of health. And finally, the framework talks about the importance of working with communities to rebuild confidence and trust through community-centered approaches, interventions that bring community together, co-production, funding the voluntary and community sector, and not assuming that the VCS can simply participate for free because it's the right thing to do. No, we have to invest and we have to value the voluntary sector. the final two sides then are really now bringing this all together. Not only do we talk about racism, not only do we have our strategic approach, but it really is now important to bring this into being actively anti-racist. And anti-racism is more than just recognizing that racism is a public health issue, and yes, it affects a lot of people, and yes, we're all poorer because of it. It says, how do I take that knowledge and now turn this into action? And anti-racism and anti-racism practices calls us to come and to be honest on understanding how racism affects lived experiences. We acknowledge that it is systemic and it's been part of the foundations of our society. And it talks about issues such as white privilege, how people who are white can participate knowingly or unknowingly in racism. It understands and speaks about the impact of whiteness, but also it says, here are some of the things that we need to do to be actively anti-racist and to move beyond simply acknowledging that racism exists. So it takes us from the place of acknowledgement into being able to have those tough conversations and into action planning on racism. So colleagues, I've come to the end now of my talk this morning, and I really wanted to start the conversation and center the day on what can be an elephant in the room, but it isn't an elephant in the room because it isn't an elephant in my room, right? No. As a black man navigating this society, it's a part and parcel of what we all have to do every day, right? So let's not call it an elephant in the room, but let's call it what it is, which is a public health issue, one that permeates everyday lives, one that has a detrimental impact on society, and one that saps our society's ability to be the best it can be. I hope that in the presentation today, you have not only a sense of the nature of the problem, what we can do about it, how we are thinking about frameworks for action, but also to think about being anti-racist as well. And I end where I started, that when we know better, we must do better. Thank you.
Wow, thank you very much, Professor Fenton. Just before I move on to the next part, I would like to remind everyone to please do share your involvement in today's summit. The hashtag is Black Health Summit 24, and do kindly tag us on social media. You'll find the handles on your tote bags and around the event as they are on screen. And just also think about the things that you would like to pledge and commit to when we go into these workshops later today, the things that you've heard from Professor Fenton, from Dr. Weil, and from the other speakers that we'll have today. Just think about those things and what you commit to as an organization or as an individual indeed. So now we would like to hear from Ovita McInnes. She is the chair of the Enfield Caribbean Association, a community organization in North London, and a steering group member of the London Inspire programme. Ovita will now say a few words on the needs for promoting collaboration and sharing best practices across communities. Please welcome Ovita.
Yes. All right, thank you. Okay. Wow. Right. Good morning, everyone. Thank you. I'm delighted to be here. I don't know how I'm going to follow that act, so you can imagine how I feel. Anyway, just to say, right, I'm Ovita McInnes, chair and trustee of Enfield Caribbean Association. I'm actually delighted to be here, and at this point, I just have to say thank you to Chedi, to Juliet, to the whole Inspire team, and to Khan, and what you've done today. It's amazing. So thank you all very much for putting this together. Brilliant. So I'm here to talk about promoting collaboration and sharing best practices across communities to improve health outcomes. The first thing I want to say is I'm an activist. And the second thing I want to say is that although we're talking about all these disparities and how sad and how difficult they are, I personally find them distressing. I'm actually distressed as a black person at hearing where we are and what we have to do. I'm also excited at the same time because change has to come, and because of people who care in the health services, in public health, in the CCGs, ICBs, and because of community action, things must change. They must. So the Enfield Caribbean Association, and I'm so glad Professor Fenton hit the nail on the head, racism is at the heart of so much that's been going wrong. So our mission statement, we started in 1986. I didn't, by the way, I was a child then. I just want you to know that. To eliminate racism, racial discrimination, and for an inclusive, fair and equal community in which people of Caribbean origin can develop their full potential as visible, positive contributors and participants in the life of the Borough of Enfield. We're a small borough in North London, and we support the community. We run activities which inspire, we hope, inspire our community. We've got very much involved in health programs and education and social justice. For example, on Saturday, we co-organised a rally in support of Diane Abbott and black women in Edmonton. So we're busy. Okay, why collaborate? Where do I begin? As an individual living in the Borough of Enfield and accessing the services, I'm just going to share one short anecdote. I had an operation at a hospital in North London, so it's personal, 5 years ago, 6 years ago, and it was a major operation. I had a catheter. The doctor said to me when it was removed, make sure that you get someone to take you to the toilet on your first trip after having the catheter removed. So when that happened and I needed to go, I rang the buzzer, 30 minutes. And then in the end, I got my mobile phone out and I rang the hospital and asked them to put me through to my ward. Now, this has happened since recently in the same hospital. I asked them to put me through to my ward so I could speak to the staff. I rang, they said, are you in the hospital? They were so shocked. I said, yes, I'm in bed, whatever, in your ward, and I need to go to the toilet, and I've been advised that I need a doctor to take me. So they were very angry. I said, will someone come? They said, we're having our handover meeting. That's what they said. We're having our handover meeting. You know the handover meeting. So no one was available, but we'll send someone. So a nurse came. She walked with me to the toilet, and then she said, do you want me to wait for you? I said to her, you decide. What could I say? You decide. And then she did wait. She took me back to my bed. I could go on and on. Every single black person in here has an anecdote. And some of those anecdotes lead to fatalities. Some of those anecdotes are really serious. So having the community voice is essential because we're now raising awareness. We all know what we want. But when we get into the system, do they hear us? Many of the anecdotes of poor communication, poor practices, lack of trust, racism, discrimination prevent black people from engaging with and receiving a good service. So rather than, oh, I've got a pain in my chest, I need to go, your brother will be saying to you, go to the hospital, go to your doctor, and you leave it because you just don't want to face what you're going to have to go through where you haven't got caring. Care is the key word for me. By the way, I need to say I love the NHS. I'm so glad that 1948 the NHS was started. I know that African and Caribbean people came in the 50s and built it and still build it. So I'm proud of the NHS, but I would like to see better outcomes. I'd like to see the disparities, and I'd like to see change. So I'm just going to talk very briefly about why and how we got involved. As I said to you, I'm an activist, so wherever there's things going on that I'm not happy with, I get involved, and our charity in North London has been amazing in doing that. So the vaccine uptake was a big issue, as we all know, in 2020, and then public health came, people like Riyad Karim, who I can see sitting here, and Dudu, and others came, and Chedi came and found us and said, we need your help. We need you to help us get Caribbean people to take the vaccine. I had taken the vaccine and I had seen my cousins and my cousin's mother-in-law, grandmother die. I'd seen about 4 or 5 people die during 2020. It was real. It was shocking. It was upsetting. And I could see that from my knowledge, by the way, I'm from education, I'm a biology teacher, so I know a little bit about vaccines. And so I felt, yes, I want to get involved. So we did. We became involved in that drive. So collaboration started. It was crisis collaboration, but it was collaboration. We produced publicity flyers, videos, Zoom conversations, vaccine depots throughout the borough, especially in the highly populated areas. There was one outside Lidl. We knew there'd be lots of people there, so we had to go where the community were. There was good collaboration with health professionals, public health and mainstream systems. So after that, Khan found us. They said, Aveta, we need you, Caribbean, the African Caribbean community. We can't stop here, because that's what was highlighted. Suddenly, we discovered that all the things that Professor Fenton has mentioned there were serious disparities around health. And Khan started the Health Hour, which has been an amazing program every Saturday. If you don't listen or see or watch those videos, you really should. So they asked us with other organisations throughout the country to get involved in that program and target 200 people per week, every Saturday, every single Saturday. A health specialist talks on a topic: heart disease, prostate cancer, urology, you name it, kidney issues, everything. Very, very, very good. So we collaborated with that and have done so. That was a 2-year program which has just ended. And then they invited us to be involved with the health festival, so we got involved in that and invited all our community to come along in Edmonton, and we had a packed hall. And so awareness in Enfield is raising, and people were having their blood pressure taken, their blood sugar taken. A couple of my trustees said, I have to go to the doctor on Monday. I said, why? I've just had my blood pressure taken and I can't believe what my blood pressure is. So it was a game changer for individuals. I'm telling you, if we save one life, I'm happy. I'm happy. Because the awareness for people to realise what they need to do and to understand. So knowledge was coming to the community. And because we have a community there at our fingertips, it was great that the health services were coming in to support us. So there were talks, there was information, screening, and we had a full house. By the way, I think they gave us 1 week's notice, Khan. I'll never forget it. Can you help us? Yes, we can. So we, as a result, organised our own health festival last October for Black History Month, which was a very unusual move for us because we usually look at history as such. But I started with a short talk on Harold Moody, who was a doctor many years ago, and some of the work he did. So I had to throw some history in. I won't go into that now because of time. But because of all our links with Khan, with public health in Enfield and so on, it was easy to draw clinicians together. And I was overwhelmed, actually, with the response. We had Black Women Rising, we had Errol McKellar from the prostate cancer group, and he was so powerful in encouraging men to go to their doctors and have blood tests to see what their I think PSA test, I think it's called, and what their levels were. And again, he is someone who is saving lives, and it was very powerful, him being there and talking to middle-aged black men. So the health, and then we launched the Community Health Forum in May 2022, and that's been going in Enfield for some time, bringing medical specialists together and practitioners, and we have a town hall meeting every now and then, regular meetings where local people come to the church. It's in a church in Enfield, and we have briefings. We have professionals who are able to talk about different health topics. So as I said, we ran our own Black History Month event in October in collaboration with Public Health, and we were able to get funding, and we had screening and people coming to have blood pressure tests and so on. And it's really been vibrant, and there were nearly 200 people at that event, which was fantastic. So I was then invited to be part of the London Inspire programme, and what's really good is that the team of trustees and volunteers are always there helping and supporting in all the activities that we do. And I'm thankful that we have the Inspire programme that's led us to where we are today. Today's conference is as a result of that collaboration, inviting someone like myself who knew very little really about health 2-3 years ago, to having a greater understanding and taking my team and other persons with me who are in the Enfield Caribbean Association. But what I want to end with is, in conclusion, which, because I've only got 10 minutes, for me is the way forward, which is really important. First of all, I'm happy to say lives have been saved because of our outreach work, because of us working with health professionals. Lives have been saved. That's past tense. We need to look at future tense. We need to look at making greater changes. And I think the key word I want to use here is I want normalised collaboration, not just in crisis management. There may be another pandemic down the road. We know what will happen if there is. So we need to be doing things now. Normalised collaboration because the people in the local communities, we know what's going on. We know what our experience is when we present ourselves to our GPs, to our doctors, to our phlebotomists. I could tell you another story about when I presented myself to my phlebotomist after retiring, walking around in my trainers and ordinary clothes as compared to when I had my suit on and my briefcase. The difference in the treatment of how I presented on the outside is incredible. Class and race. Surprising what happens. Then inclusivity. We really need to, you practitioners out there, public health people, people with power, remove the barriers that prevent collaboration. So, for example, because of what happened at North Middlesex Hospital with that lovely young man who had sickle cell, some of you know the story, they've set up a body to review practice in the hospital, to deal with racism, etc. They've invited me to be on it, but when I saw the number of hours that were expected and what was expected of ordinary people in the community, fortunately I'm in a position where I don't need to be paid, but there are people out there who would be really good on that board who do need to be paid. There was no money. I asked them, is there remuneration? So it's a barrier. If you really want people, you need to remove barriers such as that. People need to be paid. You know, black people have done too much for nothing. And it's time, okay, you hear me? You hear me? Because actually, we've really got big hearts and we're very spiritual. And so it leads us, it drives us, but actually we deserve more. Then Professor Fenton mentioned it, more research into the health conditions that affect black people disproportionately, supported by the government. That's what we need. Sickle cell, prostate cancer, lupus, just a few named. I could go on, obesity, diabetes, etc. And we need to give opportunities for black community groups and individuals to be involved in research to improve outcomes. And that's a challenge because when you have bad experiences in a service, why are you going to put yourself forward to be part of the research? But without that, we don't get a true picture of what's going on. We need to give opportunities for black community groups to have a voice and be involved in reviews of practices at all levels to improve the quality of the service provided from the time you hit A&E to your GP and getting through to see your GP and to the consultant if you have a medical concern at all levels, the nurse by your bedside at all levels. And as has been said, we need to challenge and monitor racism. And I should have said training is required, deep training, and racism and other forms of discrimination within the NHS. Thank you for listening.
Thank you so much. Right. Primary care is widely regarded as a gateway into the health system, and it therefore plays a crucial role in addressing some of the health inequalities faced by Black people. We're now pleased to have Dr. Margaret Ikpo, the Vice Chair for Professional Development and Standards, Vice Chair of Professional Development and Standards at the Royal College of General Practitioners. She currently co-chairs the Regional Primary Care Workforce Group with NHS England for the North East and Yorkshire Regional People Board, and Dr. Ikpo will now conduct a presentation on the role of primary care in reducing health inequalities. Thank you.
Thank you, Nick. Thank you, everyone. I've been told to be brief, so I'll be very quick. This is going to be a very different type of presentation, so I'm seeking forgiveness. When I saw that, I thought, should I tell them I'm now professor? So, good morning, everyone. And thank you. Thank you to London Inspire. Thank you, Juliet. Thank you, Sedi. And thank you to Khan for having me here. I work between London 2 days a week and Hull. The reason why I put the map there, because all my relatives always say, where's Hull? Are there Black people in Hull? And the reason why what you're doing today is so important is because there are lots of Black people outside London who are looking at London as the leaders in terms of how we reduce health inequalities in our systems. Part of my remit in the college is I look after the licensing exam, conference, and CPD. Just going to set my timer because of time. So before I go forwards, I'm just going to look back a little bit and ask for you to indulge me. About 50 years ago, 2 miles from here, my mother was a political freedom fighter. She came from a country formerly known as Rhodesia, following a period of incarceration. She met my father, who's from Nigeria, and he helped to set up the initial branch of an organization called the Black Panthers. So I was born into a house of protest. There was no, playgrounds for me. A Saturday was going down to Hyde Park Corner, where she was campaigning about freedom fighters and women's rights, or staging sit-ins in our local banks, because there was an art that they practiced called redlining. So if you were from a deprived area, you didn't have any access to financial services. Oh, what have I done? She set up an organisation called Akina Mama, the Africa Centre, not far from here. And with the help of Diane Abbott, they worked together with UNICEF, looking at children on the front line and how we could support them. So why am I telling you this? So I'm having to fast forward 100 slides in my head. We went back to Zimbabwe when it became independent. And that was tough. And then as a teenager, I ended up thinking I was going to go to medical school, but St. George's had a policy back then. If you were Black, if you were a woman, the computer literally said no. So I found myself in Eastern Europe. I thought, I'm going to do medicine. I'm going to do this. But faced horrendous racism, horrendous, to the point where students were injured, some of my friends died. But nonetheless, I finished. And I found myself in a bubble. And the bubble was, I shut down. I didn't know it was post-traumatic stress, but that's what happened. Until March 2020, I was on my way to work, and my daughter said, why do I have to have 2 parents working in the NHS? And I didn't want to entertain the discussion until I got to work an hour later, just before I was about to phone my first patient. And a trainee from Sudan knocked on my door, and she said, why are we still seeing people face to face without proper PPE? We are the ones that are dying. And that's what kicked me into action. I had to burst this bubble. And as Sedi said, I couldn't allow things to stay the same. Something had to change. So my dad has one of the largest vinyl collections known to man. So what I'm going to do, because I'm conscious we've had a lot of graphs and words, and before break, it's always a difficult thing to do. We only have 8 minutes left. I'm going to use vinyl. to talk about where we are and what we're going to do. So the first thing I did when this trainee came to me, I thought, well, I went on the defensive. I said, yo, listen, you need to see patients face-to-face because you have an exam. You need to be a GP. Until I did a survey, and I think I shared that with Ogie, who kindly shared that with a wider cohort, and the responses were just soul-breaking. I wept. So I thought, okay, what I need to do now is step up, but not just step up, bring everyone with me. Leonora talked about what do we do next? What's going on? Well, we know what's going on. We've had the evidence for years. What we now need are the solutions. A lot of these I will not talk about because I'm conscious have been spoken about already. But one of the things that Avita talked about was equitable access. Seeing your GP. I still have people who ring me and say, I can't see my GP. It's not... We are there, but there is a chronic shortage, 6,000 short of GPs, and they reckon 12,000 short in 10 years. But we have a wider practice team that can help us. We have care navigators that can help patients navigate their care, particularly those, as discussed before, who have language barriers, who are digitally excluded. Some of my patients don't even have heating, yet alone mobile phones. We have welfare advisors, and last week we had social workers starting in the practice, just helping people complete their forms. I remember growing up and listening to this song, must have been 1985, and Prince said something like, Hurricane Annie blew the ceiling off a church and killed everyone inside. And when New Orleans happened, I remember looking, thinking, all the black people have just literally been left behind to die. Because if you had any means of access or income, you were out of there. And something we need to be mindful is we need to continue to address the social determinants of health, housing, education, and employment. I'm currently working with RIBA, the Royal Institute of British Architecture, just looking at that and how we can do that, because health is determined very much by your surroundings at home. So these guys are both from South London. The chap in the middle is a friend of mine called Ben, who we grew up with. And COVID hit hard. I remember Donna Kinnair once saying, COVID came home. It literally came home. We all know someone who's been affected by COVID. And that's why I do what I do. Sorry, I told myself I was not going to get emotional. If you've been to any kind of African party or other party, everybody knows this song. And I remember when I was dating my now husband. So I say now husband, makes it sound like I'm going to have another husband. And it was in the year 2000, and he came home with a manual this thick, Confidential Inquiry into Maternal Deaths. And in the year 2000, if you're a black African woman, you were 7 times more likely to die in birth. And if you're a black Caribbean woman, it was 5 times. 2024, the dial has not moved much. So what are we going to do? My mum, Avita, shared a personal anecdote. I remember once she was having this skin rash and it went on, and I said, listen, we need to move beyond E45. And I didn't want to intervene because I thought, you know, as a medic, you're conscious you don't want to be the one that's harassing somebody. And eventually I had to pick up my phone and say to the GP, I need a biopsy. She had cancer. But not everybody has that privilege to ring someone and get someone to advocate on their behalf. How well do we know our communities? We've already talked about the trust issues that we have, and we are working our damnedest to try and regain that trust. We have a lot of work to do. Last week in a research meeting, someone used the term hard to reach communities again, and that just winds me up. You know, I said, it's not that we're hard to reach, we have always been right here. We've talked about the problems with finance. And every time I walk through the Houses of Parliament, they're like, here she comes, going to ask us for money again. But you know, cultural taxation is a thing. This is a systemic problem created by the system. So the onus is not on me to work free to solve a problem that affects all of us. So my message to all of you is, as Sedi said, network as much as you can today, because this feels like such a unique, and I'm honest with you, an emotional space for me. I was anxious about doing this with album covers, but Julia said, welcome. Kevin said, you're speaking to family, but get involved any which way you know how. We have patient participation groups. They're my critical friends. They'll come back and say to me, why are you sending us texts when you know the reading age in our coastal communities like 9? You know, you need to think about what you're doing. So please get involved any way you can. And I know there are some of you, and I say we are looking at all of you. So in awe, Khan, I mean, I have speechless. We have Lambeth Together, the stuff that you're doing, the stuff that the Ascension Trust is doing and Beacon Projects, the stuff that Onyi, my colleague, has done with the Bletcher Project. I could go on and on and on. We're doing lots of stuff with the college, but I'm going to end it here with this song. I've been tempted not to sing any of the songs so far. But this one strikes hard. Brothers and sisters, when they insist we're just not good enough, well, we know better. Just look them in the eye and say, we're going to do it anyway. We're going to do it anyway. Thank you very much.
Wow. We've had some absolutely fantastic speeches today and some really, really thought-provoking presentations. Just quickly before we move on to the next session, just note that we do have Slido available for people to send in some questions that they would like to have answered. There is a QR code that you can scan from your phone if you're able to from your seat, and there'll also be a code available outside. This is also being live streamed in the overflow room, so people who are not in this room will be able to watch this live. But without further ado, I'd also like to now introduce Dr. Habib Naqvi. Dr. Habib Naqvi is the Chief Executive of the NHS Race and Health Observatory, and he will be underlining the importance of tackling health inequalities in the NHS, particularly for Black Londoners, as this event is so titled. So without further ado, please welcome Dr. Habib Naqvi.
Thank you. Thank you very much. Thank you, Side, Juliet, Khan, for inviting me. It's fantastic to be here. The challenge for me is not to replicate any of my previous speakers and to cram my 15 minutes into now, I think, 5 minutes. But we will get there, of course. So my presentation will be about looking at the causes of the causes. And just as Margaret highlighted earlier, I am now a professor and not a doctor. So that is, I'm joining your club, Margaret. Just to put it into context, we know that in white majority countries, the discrimination that we face, the racism that we face isn't just related to health or employment, it's wealth, it's housing, it's how the law is applied. And of course, in these countries, Black and ethnic minority people have the short end of the straw, as we've heard before. One of the first things we did when we set up the NHS Race and Health Observatory over 3 years ago was to carry out a rapid systematic review in terms of what is the evidence base in the here and the now. Yes, it was partly in relation to a response to the CRED report, but at the same time, it was also an opportunity for us in the observatory to outline exactly what we need to do in the following 3 years. And some of the topics that were looked at by the University of Manchester and others included mental health, maternal health, genomics, and employment, etc. However, this rapid review did make the front page of the newspapers, not because it was another rapid review, but because perhaps for one of the first times in the NHS's or the healthcare system's history, we were explicitly talking about anti-racism. And when we talk about anti-racism, we talk about, on the far left, the structural racism that we see within society with regards to legislation, with regards to employment, with regards to education. On the far right, the cultural racism, the stigma, the trauma, the behaviors, the day-to-day racism that we see within our organizations. And of course, that institutional racism, how that then transpires in the policies and the procedures that we work with day in, day out, and in fact the NHS has worked with for decades. Kevin and others highlighted the point around trust, and I will highlight this, and I've kind of stolen this from Kevin. In fact, I think Kevin stole a slide from me, so we're co-producing here. Kevin often talks about trust being truth told consistently over time. It cannot be right that leaders, politicians, on one day talk about challenging racism and on the day after deny racism. Yes. And we see this day in, day out. And when any part of that equation is broken, trust and confidence is reduced within the communities. This is our fundamental principles around having a kind of an anti-racism approach to the work we do. And again, I think it was Kevin that said, you need to see it, say it, and act on it. And it is about naming racism. It's about having fully engaged working relationships with your staff, but also that meaningful and sustained engagement with your communities over time. It's about collecting data, so you know where you are, where you need to get to, and how you're going to get to that place. It's about identifying racist bias within policies, processes, and behaviours, and it's about evaluation. And that's the approach that we take within the NHS Race and Health Observatory across a range of areas that we've been working on over the last 3 years, from some of the deep-seated inequalities that we see in maternal health and mental health, in terms of COVID vaccine, in terms of sickle cell disease, looking at genomics, looking at education, looking at research and diversifying education and research, what gets taught, what doesn't get taught, who leads the research, and of course, partnerships and global working. A program of work that Yvonne Coggill will be speaking later today with Professor David Williams from Harvard are leading on as well. And at the heart of what we do is that engagement with our communities. In fact, Charles is part of our stakeholder engagement group. We do not do anything within the NHS Race and Health Observatory without that group having a focused approach and making those decisions with us and co-producing everything that we do. We bring together the evidence base, we use that evidence to inform policy, and then we focus on transformation. Some of the transformation that we've focused on over the last 3 years includes our first piece of work around racial bias in pulse oximetry, which in fact led to the independent review commissioned by Sajid Javid, which in fact, interestingly, originally was labelled racial bias in medical devices, but was then changed to equity in medical devices. That report was published by the Department of Health 2 weeks ago, and thankfully the coverage of that report did highlight back to this report on the far left that we produced nearly 3 years ago, highlighting the racial bias in medical devices more generally, but also in pulse oximeters as well. On the far right, we're looking at neonatal testing, and again, some of the biases we see in things such as the APGAR score and jaundice testing, and we are working with the Institute for Healthcare Improvement, looking at an anti-racism approach, using those principles I highlighted before, to work with 8 ICSs across the country, including 2 in London, to do some very deep dives around this work as we move forward. And of course, looking kind of upstream, Kevin mentioned the lack of representation in clinical trials, which is absolutely right. And that's one of the reasons why we then get devices, we get medical assessments, we get drugs and medications that are not always fit for purpose for our diverse communities. And we're looking at a program of work to increase representation in breast cancer trials with the Christie Hospital and Barts in London, working with Macmillan Cancer and Roche on a concerted piece of work around that. And again, we know that, I guess, if we're in the business of tackling health inequalities, which we are, we need a workforce that's fully engaged and fully supported at all levels. However, in London, we also have this kind of data. This is a few years old, but I don't think it's changed significantly. The red bars are black and minority ethnic staff, the blue bars are white staff, and this is data for all hospitals in London. As you can see, as you go up the Agenda for Change bands, the red bars drop and the white bars increase. The green horizontal line is the overall BME workforce across London, which at that time was around 44%. I guess if we're in a place of equity, we would expect the red bars to be hitting the green line right across the pay scales and not just at the lower ends. It's not just opportunities, of course, where we face challenges, but also in terms of experiences. This is the latest data produced, 2023 NHS staff survey data, which was published 2 weeks ago. The RES data was published, I think, a week ago. This is a response to a specific question, which is around discrimination and the reason for the discrimination faced by the member of staff. As you can see right at the top, consistently and persistently, the reason for discrimination on the basis of ethnicity. You haven't got the key here, apologies for that, I think it's dropped off at the end. But the top line is discrimination on the grounds of ethnicity and race. The other lines below that, the red, green, yellow, etc., is discrimination with regards to other protected characteristics. And of course, we do have the intersectionality, but this was a specific question with a specific answer as to the root cause of that discrimination. And in fact, in 2023, for the first time, since I think records began on the staff survey, we have gone above the 50% scale in terms of responses. So that's the scale of the challenge that we have here. But of course, it's not just about outlining the scale of the challenge, but it's also about, as my clicker doesn't seem to be working, it's also, I'll just talk, it's also about outlining solutions. And some of the key solutions that we do highlight in terms of the work that we've done in collaboration, for example, with the King's Fund, is to make sure that we have diverse leadership at all levels. It does work now. And that's a key element for change. Secondly, to invest in health inequality leads, to invest in ED&I, just as Kevin and other colleagues have highlighted before, to invest in engagement, but engagement that's sustained and meaningful over time with our staff and our communities and not piecemeal, as historically we probably have done as a healthcare system. To focus on what we call the causes of the inequalities. And of course, when COVID broke out, we were aware of the messages we were given from high on up around the causes and the disproportionate impact upon ethnic minorities. Kevin highlighted those eloquently before in terms of comorbidities, in terms of living in multi-generational households, in high-story apartments, in working on the front line, but we were not told about the causes of the causes. Why is that in the first place? So being true to our kind of our beliefs and our values, we need to focus on the causes of those inequalities, and to focus on that as we move forward. And of course, that is my final slide. If we are to close down the gap between the promise of our ideals, as the previous speakers have highlighted, and the reality of our time, and some of that reality, of course, are the disparities that we see in experience and in outcomes for our patients and our staff. We need to make sure that we are focusing on our values and having our moral compass pointing in the right direction so that we can see it, say it, and act on it. Thank you.
Thank you very much, Habib. So coming up on the screen should be 6 workshops for this morning, which we'll be breaking out into. Please have a look behind your name tags. There's little stickies on which workshops you've been drafted into. And in keeping with the theme of the summit, we are having a focus on the various health conditions and well-being issues to explore best practices, insights, and value of cross-sector collaborations aimed at improving Black maternal health outcomes. Sorry, just wait just a little bit. I'm just still reading. I know you're all eager to get to your workshops. I just want to round out before we head into them. As you can see on the screen, you have the main auditorium: cardiovascular disease, hypertension, food insecurity, immunization and screening, sickle cell, maternal and neonatal health, mental health in young people. Please do move into your respective rooms as described on the board, and teas and coffees are available, and then we'll be back in the main room afterwards. So thank you very much for joining today's session, and enjoy your workshops.
in a session about cardiovascular disease, and again moving from knowing the disparities into moving into action. And as ever, we have fantastic people that are going to be talking you through, leading you through the discussions, and then I'll be here to facilitate. So we have Dr. Faye Ruddock here. And we also have Julie J. Charles, CBE. And I missed the memo because I'm not in green, but I won't be offended. I'll take it as it is. But I will hand over to these wonderful ladies to introduce themselves.
Thanks, Vanessa. And yes, it was not planned, definitely not planned. I think we're the only two in this kind of green as well. So good morning, everybody. So I'm the chair for the Caribbean and African Health Network. So we're the machinery behind today's event. Thank you. So yes, I do a lot of work around health inequalities in the Black community, started years and years and years ago. And I keep saying, as my chief exec keeps saying as well, COVID did not teach us anything. We've been working on this agenda for years and years and years. So this is very, very much a very welcome conference for us, because we are talking about solutions. We're not talking about what the issues are. We know what the issues are. Let's get on and let's bring about the solutions and the changes that we need to see. So it's very, very much about that on CVD today. And we will just want to have conversations with you and to find out what's really going on in your spaces where you are. But just a little bit about some of the things that I do. I direct the Health Equity and Social Justice Institute as well. Again, making sure that we embed health inequality and racism and everything that's been said today. I think my presentation, like Khabib said, it's going to be like 5 minutes, because everything that's been said this morning already is what I had in my presentation. So we just want to really have the honest conversation about what's really happening in this space to make the changes. So I'll introduce, Julie, do you want to introduce yourself?
Yeah. Okay, I'll say my name again. It's already been said. I'll say it again. My name is Julie Charles. Many people call me by my full name, Julie J. Charles. Yes, I am a CBE. And those of you wonder, why did she get a CBE? Mine came from someone who had lived experience of a number of illnesses at the age of 17, and worked my way up to being a ministerial advisor in the Labour Party some years ago, 15 years ago, and also founder of NICE, the National Institute of Clinical Excellence. I have done a lot of work in the community. I had a voluntary sector organisation called Equalities National Council, that actually was going for 25 years, and Equalities ended during the pandemic because we was no longer able to do advocacy, outreach, and support people that were in the criminal justice system, and mainly black males. My work has gone on to right now working in the NHS, in quite a senior position, and what I've found is that as a patient myself, but a human being first, and the patient to the NHS, that there seems to be a lot of ignorance around the black health matter. You know, what does black health mean to a white nurse coming from a rural area in, I don't know, Dorset? You know, what is it? What does she know about sickle cell? What does she know about lupus? How does she know how different things affect us? And I'm coming from a space where my health has been jeopardised because of a lack of knowledge of what my impairments have done to me, because of lack of knowledge of nurses and doctors that should be treating me. And I think that, I know I'm going off on one, but I think that it's really important that when we talk about hypertension and CVD, that we've really got to think about how we bring it all together, that somebody can have heart disease, but they can also have mental health, live with mental health. Someone can have lupus, which I've got, and I've also got heart disease, but you can also have arthritis because of the cause of the heart disease or because of the cause of the mental health treatment that you're on. Yeah, and so I think that for me, today, it's about just being open about what it is that can go wrong and what it is when it goes right, how it can make your life a totally, totally different place.
Thank you so much. And one of my roles was just now going to give an overview about cardiovascular disease and awareness, but I don't actually think we need that because you said it so beautifully, because I think the lived experience is the most powerful narrative about this. What I would only say is that it is one of the biggest killers globally amongst our communities, but also that it's an equal opportunity threat. So many people will think of cardiovascular disease as a male disease and often forget about the female component, and that we suffer significantly as well. And that's a really important area that we need to think about, but we'll bring that in the discussions. Faye, do you want to just give an overview from your point of view?
Yeah, sure. So for me, CVD work started back in 2009 when it was a piece of work. In fact, it was actually a part of my master's where I wanted to look at why do we have such sustained CVD issues? Who's talking to communities? So, cardiovascular disease.
Oh no, I think you heard B is V, cardiovascular disease.
Yeah,
I thought you said.
CVD.
Yeah.
Yeah. So trying to understand if we've got such prevalence of cardiovascular disease, who's speaking to communities? Who's actually speaking to the people that have got the challenge, the health issue? So when I did that piece of research to find out that actually, this is when we had the Primary Care Trust, actually finding out that no one was speaking to communities. No one was actually speaking to the people. And what that led me to do was to start a PhD, because you can't get that information and leave it, you know. It's like we need to think about, you know, what else do we need to explore to take it to the next level. That's when I started my doctorate, which started CARN. And basically what people were saying in the communities, we had hundreds of people coming together to look at, you know, what the issues were. You know, I showed them
tell him 1 second. Don't worry. That's cool.
In the hall, in the foyer, but also the.
What I should say is that day's gone to the toilet, so you might just need to give her a couple of minutes.
Okay.
No worries, no worries.
But yeah, do you need me to do any shuffling with people to get them back in the
Yes,
room?
please, if you don't mind. Yeah.
So,
Oh, she's come back. She's back. But also, on the health hour, it's on everybody's bag. If you mention we've got health hour every Saturday, so people can get the
sorry, how?
it's called, okay, so this, oh no, we're taking it out. It's called the health hour on a Saturday.
Health hour.
Because everything we've been talking about is about health prevalence in black communities. So we've done all the conditions this morning, but every Saturday in Calm we have an online health. Minutes afterwards, we can make it.
I was writing it down somewhere for you.
Yeah, please do. Yeah, there's a lot of information.
Are you able to put it on?
Put it there.
Yeah. Sorry, one last thing. Do you have to mention cancer carers or doing screenings?
Yeah.
Yeah, I think so. So, no, you can sit down. Yeah, I'll invite you one by one. Asia.
I think about me. You guys call. You guys can call it to me, and I'm not calling yet. You'll be fine. I'll sitting down there, and then you can.
I mean, if sit down first?
And one of the speakers, came up, fell off the stage. Very polite.
Yeah, I mean, if you want to sit down first, so carers for okay.
That's what I'm saying to you.
And Khan has a yeah. Actually, might as well. Yeah. We'll just time to come in.
I know.
We'll start just now.
Yeah.
Okay.
Yeah, okay.
Cool.
Thanks, Lee. Yeah, and then the health hour on a Saturday.
Health hour on
your back, on your toes down, all the luck.
Hope everyone's getting. Whoop. Hello? If everyone can make their way to their seats and we can get started with this panel session. Hi. Yeah. If everyone can make their way to their seats. All good? You all okay? All good? Okay. We're still waiting for a few more people to come in.
I thought there was wasn't Kevin.
Yeah. Should I start? We're just waiting on one more person and then we can make a start. Okay, we're going to make a start. If we could just have a bit of quiet as we kick this off. Thank you very much. Thank you. So this next part to the event is to do with system and cross-sector collaboration. Just a few little bits before we get started. Carers for Carers are conducting health checks outside, so people could please make their way there afterwards and make use of that. And also if you could refer to the information on your tote bags, which is about the Khan Health Hour, which is held every Saturday. You can sign up and learn more from the information that is provided. We will have lunch at 12:45 as planned, and those with green lanyards will be able to go first, and anyone with a condition that's stated during registration, then 20 minutes later, those with red lanyards will be able to go afterwards. So, as we... Just waiting for more people to make their way forward. So, as I said, today's panel session will be on system and cross-sector collaboration. I'm just going to introduce our panelists as they are here. We have Stuart Love, who is the Chief Executive of Westminster Council. We also have Dr. Lade Smith, who is the President of the Royal College of Psychiatrists. And we also have Dr. Vishal Virani, who is the Head of Health at YouTube. We were supposed to have Jeff Booth, the Chief Superintendent at the Metropolitan Police, but he could not make it, unfortunately. And we also have Professor Kevin Fenton, who hopefully will be joining us later. But each of the panelists will start with an introduction, a short introduction, and then we can move on to questions and discussion. So I'll start with Dr. Lade Smith, if we can, please.
Okay. So thanks, everyone. Thanks very much indeed to Khan and to Juliet and Sedi for inviting me to be on this panel. And frankly, I thought I'd be able to be very excited about everything. But I have to say, after this morning, I'm a little bit disappointed. And the reason I'm a little bit disappointed is because despite the fact that the main health condition that black people, there is this huge disparity on being mental illness, and we've seen enormous racial disparities, as you know. Don't have to rehearse them, but for those of you who may not know, basically, if you are black in this country, and this is something about being black in a white majority country, because the same thing doesn't happen in black majority countries, you are 4 times more likely to be detained under section. You are much more likely to have a diagnosis of psychotic illness. You are far more likely to not be able to access mental health care, if just through the usual routes, like referring to talking therapies or via your GP. In fact, 40% of black people enter mental health services via the police when they're in crisis. And once you're in services, people report worse experiences, and there are also worse outcomes. Given that these are the worst health disparities that are going on, the reason I'm disappointed is that it wasn't mentioned once this morning. Not until 10:46, when Margaret mentioned the post-traumatic stress that she had, and it was on one of her slides. But actually, it's really the main problem that we have in this country that arises as a result of the structural discrimination that we see. And in fact, the fact that mental health and mental illness wasn't mentioned at all is in and of itself something of a discriminatory process. We saw it in action this morning. Literally, there is structural discrimination when it comes to mental illness. And of course, if lots and lots of black people are experiencing mental illness, then they're going to be doubly, if not trebly, discriminated against. And for those of you who sort of think, well, you might be feeling a bit guilty now, but sorry about that. But I'm a mum. I'm a black mum. That's what I do to my kids. Anyway. But there is also another thing, which is this. If a person has a severe mental illness, and that's something that many black people have experience of, too many, then it also is associated with significant physical health problems too. So people who have severe mental illness are much more likely to die 15 to 20 years earlier, not because of suicide, not because of accidents, but because of the same things that everyone else dies of. That's cardiovascular disease and respiratory disease. If you have a severe mental illness, you are much more likely, you're 3 to 4 times more likely to have type 2 diabetes. You are much more likely to have what's called the metabolic syndrome, basically that triad of risk, the adiposity, fat around your important abdominal organs. You're more likely to be hypertensive, more likely to have dyslipidemia, more likely to have diabetes and insulin abnormalities. And yet what we're doing about that is just not enough. We've talked about the issues in mental health for years, right? We really have, 40, 50 years. People said it's about, big arguments about, it's misdiagnosis. No, it's not, it's genetics, said people on the other side. And actually, what's going on in the middle of this is it's actually quite simple. We know what causes mental illness. What causes mental illness is, in fact, we know that genetics and familial things are important, but there's also an excessive increase of trauma, adverse childhood experiences, and life trauma as well. You know, employment problems, financial issues, poverty, and so on. All of those social determinants are much greater in black people than they are in everybody else, especially those adverse childhood experiences. If you have 4 or more adverse childhood experiences, then that increases the likelihood of you having physical and mental disorders, quite significantly so that they shorten your life. Now, that is something that's not lodged in the individual. That's something that we need to change on a systemic level, and that's what we need to be thinking about. Just to say, there are some things that we can do about it. Number one, I would say now, I never used to say this, I never realised this until a few months ago, that the first thing we have to do is think about people with mental illness, because actually they're the ones who are most marginalised. If you're black, you're marginalised. If you've got mental illness, then you are doubly marginalised as well. If we develop services and our systems so that they, instead of thinking about the majority of people, the average people, we actually design those systems so that they work for people who are at the margins, the most marginalised, then they will work for everybody else. Thank you.
Thank you very much. Professor Kevin Fenton is now joined. So we'll move on to Vishal next, just from left to right. So Vishal, take it away.
Thank you, and thank you for inviting me, Khan. It's a real pleasure to be here. So, as Nick said, I'm a clinician by background, but for the last few years, I've been looking after the YouTube Health Initiative in the UK. And so, a very nice segue from what Ladia was saying is that actually, I think there is a real power with YouTube to access to access a broad range of communities and ethnicities and provide the right message to sometimes those hidden parts of the population that are not receiving or acting meaningfully upon the messages that are currently being shared via patient leaflets or via their doctors or whatever it might be. You know, I think that YouTube provides such a range of different voices that we can leverage, and that all of you guys in the room could leverage, either in terms of consuming that content, but also start to think about how you might create content. There are so many of you in this room with real expertise around topics that affect black communities and others, which are just not being represented necessarily by kind of the patient-doctor consultation or by the information that the NHS is providing at the moment. And so that is an impetus for you guys to consider starting a channel, getting together with others, and creating that content that will target people in the right way and encourage them to take some action on their health. And so that's, I guess, why I'm here today, and that's why I was keen to be part of this panel. Just very briefly, a couple of things that we are doing at YouTube Health. In general, there's one thing that we're doing, which is around raising up high-quality, authoritative health information. So if you search for any health topic, at the top of the search results, you will see a shelf labeled from health sources. So that contains videos specifically coming from authoritative sources. That's not just NHS organizations, but also a range of different health charities. For example, Tommy's is out there, and they are part of these health shelves, and lots of individual clinicians. And actually, it's the individual clinicians where we have such an opportunity, because they cut across a range of different ethnicities and are speaking to a range of different communities and different age ranges and different genders as well. And so that's one thing we've got. And then we've specifically recently launched the Health Inequalities program, where we have got together 10 organizations and individuals in the UK who are specifically creating content to target it at underrepresented communities. So we've got organizations like 5X More, who are specifically focused on black maternal health. We've got individuals like Dr. Samia Dedeji, who talks a lot about skin health and women's health, especially in the Black community. We've got Dr. Aziza Sese, who does similar things for women's health content. And so we've provided them with grants, and they're part of an accelerator program in order to sort of help them refine their messages to those underrepresented communities. And then we've also got our YouTube Black Voices Fund, which is across the board, not just for health, but again, this is where we're funding a range of different creators within the Black community to share their voices. And there's a couple of doctors who are involved with that as well. And the final thing I'll say is a really interesting project that we part-funded during the pandemic was in the US with the American Public Health Association, who ran a barbershop medicine series where they got together local community leaders plus health experts in a local barbershop to talk about the pros and the cons of the vaccine, talk about some of the concerns that the local community has about the vaccine. And, I guess that one of the objectives was try to get people more comfortable with the vaccine, not necessarily say you have to take it, but at least let them understand what the facts were from health experts within that community setting. So that was a really interesting project. So anyway, more than happy to talk to you guys afterwards about some of those things, but thank you for having me.
Thank you, Vishal. Stuart?
Good afternoon. I'm Stuart Love, Westminster City Council's Chief Executive. I also chair the London Council's Tackling Racial Inequality programme. And as with everybody else, just a huge thank you for having me along this afternoon. I've been Chief Executive of Westminster now for 6 years. And in my time in that role, I have put tackling equity, diversity, and inclusion right at the heart of everything I do and everything the organisation does. It's as a result of decades of racism and sexism that we have wicked pay gaps in our organisation, a lack of representation, and a range of other things that need tackling. But it also, because of that, has resulted in much poorer outcomes for our communities, and in particular our diverse communities. About 8 years ago, the council used to have a standard presentation that we did for inductions and other, it was just a standard presentation that I think most local authorities have. And there was a bullet point in there that said, if you were a man living in one of the wealthier parts of Westminster, you would live 10 years longer than a man living in one of the more deprived parts of Westminster. We have some of the wealthiest and some of the most deprived parts of the country in Westminster. And that's where it started and that's where it stopped. We did nothing about it. There was a bullet point on a presentation. We look at that now, and that life expectancy gap is now 18 years. It's appalling. What has changed, though, in the time, and I'm sitting here saying I've been chief executive while that has happened. But what has also changed is the makeup of our organisation has changed. We are now much more diverse, much more representative, and because of that, our communities are now much more prepared to engage with us and listen to us and work with us. And for us, we are a much more listening organisation than we used to be previously as well, which is critically important. And I'm hugely grateful that you've got me up here this afternoon, but the really important thing for me actually is to listen and learn, because the public sector is still largely run at a senior level by people who look like me. And it's people who look like me who have to be accountable and responsible for driving the change that we all need to see. And I need to hear what is said today, so I can take that back into my organisation, which some of my colleagues are here as well, and make sure we continue to drive the change that we need to see. So thank you.
And Professor Fenton.
So hi everyone. So you're seeing the cloned version of Kevin Fenton here. The other one's upstairs giving a talk. So we met this morning. I'm a public health physician. Many of you know I've been involved with research and programs and policies to tackle health inequalities since the 1990s in my work on HIV prevention here in the UK. And over the past 30 years, I've had the privilege of serving both here in the UK, in the US, and globally. And the constant thread in my work has been social justice and equity, because there's no health for the population unless there's equity. There's no health for all unless there's social justice. And so therefore, a key part of my work as a public health practitioner is to ensure that we not only develop evidence-based programs, that we not only work to identify policies that work, but underpinning all of that is justice. In the presentation today, I reflected on our understanding and role and journey on tackling racism, looking at structural racism. I think what I wanted to perhaps reflect on here is, and now, is what got us to this point is not going to get us to where we want to be, right? There is enough of us doing the same things over and over again and getting not only the same outcomes, but worse outcomes. So the question we need to ask ourselves is, what do we do that fundamentally breaks this cycle and creates a legacy that when all of us here move on to new roles or retire, the baton is passed on and this journey and this fight continues. So I'm so pleased today to see so many young people in the room, and I've had a chance to meet a number of you in the breaks, because you give me hope that actually the lessons and the doors which are being opened now will continue to be opened, and your voice of advocacy will continue to be strong and powerful and impactful. And a key part of that for me is, number one, speaking truth to power. Your voices are so important. For all of you in the room who are HIV activists, can you just raise your hands, please, our advocates? Yeah, I just want to give a shout out to my HIV tribe, because in 4 decades, we have gone from an unknown disease that was driving fear and stigma and death and despair around the world to the point where we can now see the end of this pandemic and the end of this epidemic and transmission in this country by 2030. That's a phenomenal achievement. And when the story is told, they'll want to say the story was done and the journey was achieved by the scientists. It wasn't only the scientists. It was your powerful voices that did it. So my introductory comment today was to reflect on the power that you all have. Understand it, acknowledge it, use it positively, be part of changing systems, because that's where real change occurs, and support each other on that journey, because this is hard work as well. All right.
Thank you very much. I'm just going to kick this off with 1 or 2 questions, and then we'll open it up to the rest of the audience to engage in the discussion. I'm just conscious of time, so I'll keep mine brief, and then hopefully we can get some questions in before lunch. To start off with, I think, Lade, you've identified the problems that are found in mental health and some of the barriers to that. I just wanted to wonder from your perspective in terms of what kind of ways can we foster effective collaboration to break down some of these barriers from an organizational perspective in terms of cross-collaboration. What are some of the ways that we can get through that?
So I was talking about this earlier in our workshop, but there was a recognition actually before COVID and before the pandemic that there have been issues, and there have been lots and lots of work over the years trying to understand why these massive disparities, particularly in mental health, and what can be done about them. And unfortunately, the arguments, as I mentioned, really distracted people. But there was a Mental Health Act review. One of the main things was to try and find recommendations, thoughts about how we could reduce the disparities. And one of the things that came out of that was the Patient and Carer Race Equality Framework. It is an organisational competency framework, and the idea is that you, whatever type of organisation you are, in this case, health organisation, you accept that you don't know it all, right? Number one. You don't have all the power and you don't have all the control. And if you did, then things wouldn't still be the way they are. You actually actively go out and find people in the community, and you partner with the people in the community, and you support them to be able to be in the room with you. And that simply doesn't mean getting one person who puts their head above the parapet and then bringing them in, because they often get overwhelmed. It means supporting people so that they can understand the language that you're using, so that there can enough of them in the room. So it might be groups of people, and it might be people who are in the community they might be people who have experience of your services, but also people who might not have experience of your services. But you also ensure that you've got people who are carers and people who have lived experiences of your services directly, and you work together in partnership. and you find out what their needs are, and then you develop your services determined by what they say they think that they will be able to accept and work with. And your expertise is to say, well, this is what we know works. And they will say, well, if that's what works, this is how we want it delivered to us. And so that is what people are starting to do now. That's been rolled around, it's been piloted in 4 trusts across the country. I think from March, April, it's been piloted, it's been piloted, it's been rolled out across the country. Obviously, some places are going to do it better than others, but we have seen that there are people who are doing this well. We've seen people who are not doing it so well as too, actually. But it really does require people on the ground to get involved. And essentially, it's about being a good neighbour. And for once, seeing these group of people as individuals, not just as this group that has characteristics that are generally negative characteristics.
Thank you. I'm just going to ask one more question and then open up to questions. From your perspective, Stuart, as a local authority leader, I'm just wondering, how can you shift the dial towards sustainable change from your perspective, especially when we're talking about Black-led organizations in the community, in health and social care and so on? From your perspective, could you briefly give us an understanding of how you can shift that in a better direction?
Yeah, I mean, we, as you can probably tell from my opening remarks, are starting from a pretty low base. And what we have done over the last couple of years in particular is we've started to invest directly in those kinds of community organizations. We've invested directly in the organizations. We also are investing in training around health issues for the people who lead those organizations. So the way we make this sustainable is so that it no longer becomes what we had traditionally done, which is a sort of parent and child relationship between the council and our community. It's getting our community much more involved and the community making the decisions. We have to listen, we have to take no for an answer as well, something we may not particularly have been good at in the past. And the other thing we're trying to do is we're trying to involve our anchor institutions as well. And I think this is really important because a place like Westminster, we've got huge organizations here that are incredibly wealthy, and we're asking them to, alongside us, invest back in our communities because they are making their money in Westminster and they have a responsibility. A lot of them have been around longer than the council and maybe around longer than the council exists as well. So using our anchor institutions to not just to leverage funding, but to leverage expertise as well, to go back into our communities and help our communities, which ultimately is how this becomes sustainable. That investment we're making now is with a view to this being a medium and then long-term program.
Thank you very much. Now, we don't have a ton of time, but I'm just going to open up to the floor for questions. There should be a roving mic somewhere, so then we can hear. If anyone wants to start, I'll pick up some hands. Yes, the woman here. If you could please state your name, where you're from, and just briefly your question. I'm just waiting for a mic to come if it's around. No? If you're able to stand up and ask a question.
Good afternoon, everyone. I'm Kenisha Jackson. I'm a child and adolescent mental health, a child and adolescent psychotherapist. I recently did some research looking at the underrepresentation of Black children and students accessing mental health services. We heard in our workshop earlier this afternoon that researchers run the risk of their research being marginalised. So you first want to do the research, but then you run the risk of it being marginalised. Thank you. Just getting started. So I quite liked what Stuart said, is that we've heard about the Black community being hard to reach, but we know that actually it's the services that are hard to reach. The research showed in the outcomes that parents work so hard to try to navigate the NHS system to get the help and support. It required so much resilience, but what about the children and families that don't have
the staying power to navigate the systems. So we know that there are organizations that are working well with the community. So yes, why can we not invest in them? Why are they having to chase funding? We need to do things differently. We need to ensure that children and families are accessing not just mental health services, but talking therapies. They're going into the organizations and they're quickly being diagnosed and offered medication, but they're not being offered talking therapies to get to the root of the matter. And much of the matters are intergenerational, based on racism and trauma. And we need to start there if we're going to see sustainable change.
Thank you. Can we pass the mic down here to this? Yep, just pass it down. State your name, where you're from, and your question, please.
Thank you. My name is Loretta Oduware Ogboroko, consultant obstetrician and gynecologist, Rotherham Hospital. I just want to follow on what you've said. I think the question we should be asking is how many of the therapists speak the language of these children?
Thank you. Just one more question, just at the back, that she has a mic. Yep. If you could state your name, where you're from, and your question, please. We'll take one or two more after this, depending on time, and then we'll close it and have some closing remarks from the co-chairs of...
Okay, hi, sorry, God, I was getting panic attacks. Okay, my name's Evelyn Mensah. I'm otherwise known by my friends as Evie. I'm a consultant ophthalmologist. I've worked in the NHS for 33 years. I'm the clinical director for ophthalmology at London Northwest. So the question that I wanted just to, and I say I'm only giving the NHS 2 more years of my life, and then I'm gone, and then I'm gone, all right?
Don't say that.
I don't usually have my fingers this way, but anyway. So the question I wanted to, Laddie, I was just, what you talked about when Professor Fenton omitted to talk about mental health within our patients. I would also say the same thing for the workforce. I would say that that the systemic racism that the NHS workforce, particularly our black women, 100%, 100% is off the chart. It is underestimated, and you need a healthy NHS workforce to be able to provide and deliver the care for our patients. It is underestimated. We already know the racial disparity that exists for formal disciplinaries. Formal disciplinaries are used to weaponize systemic racism, and it's used to target the workforce. And within our organization, with work that I had the privilege and pleasure of doing with Yvonne Coghill in my organization, London Northwest, we disaggregated Res 3, which is the Res 3 is about the percentage or the proportion of people who are referred for formal disciplinaries. And in my organization, if you are black, you are 5 times more likely to go along the formal disciplinary route. If you are South Asian, you are 2.25 times more likely compared to our white counterparts, which is more than the national average, which is just 1.1 something. So I already know of some NHS staff who have been so traumatized by the racism that they've experienced that it's induced psychosis, schizophrenia. It's really too much. So whilst definitely our patients, we have to look after ourselves, we have to heal ourselves. And just quickly for the CEO for Westminster, I think that you guys were probably the first council that I ever encountered, and I do quote you in my slides, of using the aggregated term global majority. And I wanted to say thank you for that.
One very, very, very last one, and then we'll move to one remarks. I know that this room is full of enthusiasm. We'll just take this woman here, very, very last one.
You have to stand up for what you need. Okay, so I'm Abigail, and thank you, everyone. My question is for you, Vishal, actually. I'm a registered nurse and founder of Health in Check. I often find that when I'm educating or helping patients within the hospital settings, I don't really have, the opportunity to be quite unique and creative and helpful even with my, advice. And I find that we often give a lot of prescriptive advice, like eat 5 a day, right? But on YouTube, I've actually started creating educational videos, which have, been getting quite good engagement. So my question for you is, how can I obviously use my expertise and benefit, because obviously I think tech and healthcare will go hand in hand to actually affecting the change that we need to see. You might need to take it off, but
Yeah, no, sure. I guess you'd like me to hack the algorithm, right? So we get you at the top of the search. So we'll work on it. But no, I mean, it's fantastic. Fantastic. Really pleased to hear that you've been getting involved with creating content. And as you say, it is a creative outlet as well. There are various sources of resources available, like on the YouTube Health website. We've got some videos around best practices. There are, Laddie and I are in discussions to sort of create some type of support program for psychiatrists in particular. We ran an accelerator last year. So there's various things we're always looking to do for the clinician community and health charities to upskill them and get them sort of interested and engaged with creating content online. So yeah, happy to discuss that with any of you guys afterwards. So thank you.
Thank you very much. I'm going to have to close it there. So I'd like to thank you to the panel for coming up and providing us with their thoughts. I know that a lot of you had questions that you'd like to ask, but I'm sure that you can find the panelists later on. I'm now going to leave it to Sedi and Juliet Juliet and Sedi to give us their closing remarks for the morning. Thank you very much.
Thank you very much, and thank you, Nick. I'm very conscious that we're keeping you away from your lunch, and those of you with blue lanyards, oh no, sorry, there aren't any blue lanyards, sorry, forgive me. Very, from me, very, very briefly, Juliet may have something to say. We've been planning this event now for months. This was the vision of Dr. Julie Hammond in terms of bringing us all together. And we must have had 24 planning meetings, which I fully engaged in, but I missed something absolutely fundamental. Today is as much about civil rights as it is about health and health inequalities. The agenda was set out. The speakers we heard this morning actually, in part, ripped the agenda up. Because what they wanted to get across, from Kevin to Margaret to Avetta to all the speakers, was actually there's something fundamental that we are missing as a people. Not just in London, but nationally. So one of the big takeaways from me this morning is actually this is very much a civil rights movement as much as it is a health movement. Thank you very much.
So, as always, I agree with my co-chair. I dare not. So, absolutely. And I think, Avetta, you talked earlier about activism, and I think that is absolutely, the case. And how do we do that? Just a little call out. So those organisations who are black-led in the room, if you would like to be on the Inspire website, please do contact us, because a couple of people came to me saying they didn't realise that actually we would promote you. So we've done some mapping across London. So if you are, then do contact us, and we'll make sure you're on the website and you can put your events on a programme. I'm not going to say much more because I'm sure you're all really hungry. But thank you. It's been an amazing morning. I think it's been really emotional, and I think Margaret talked earlier about it being emotional for her. I think most of us it's emotional for. I've often been told it's not emotional, it's not personal. I think it's both. And it's highly personal. So enjoy your lunch. We've got a great afternoon planned. And thank you for all your contributions this morning and the workshops. We'll see you after lunch.
Hello. Good afternoon, ladies and gentlemen. We need to crack on, so please take your seats. And we just thought we'll break it up a bit and give you some performance. So sit back, relax, and you have me for the afternoon. Thanks. So this afternoon, to lighten the afternoon before we crack on with the second half, is the UK Africa Cultural Acrobatic Entertainment Group. Can we put our hands together for them as we welcome them to the stage?
I'll try to go down. Two. Hello, everyone. Two. Hello, everyone. All right. Thank you very much. You are sitting down nicely. We are UK African Acrobat Cultural Variety Entertainment. We are originally from Ghana and we perform. We have been performing for all kinds of events. We also do corporate school workshops, parties. Sometimes we even perform for divorce parties and things like that. I'm not saying you should divorce, but we want to separate you nicely with good friends. If it doesn't work. Anyway, that's one of the jokes. We're going to give you some short entertainment. And if you want to join us or come on stage, raise up your hand. We're going to do something, we call it interactive performance. A big round of applause. All right. Do you like singing? Okay, if you like singing, we're going to start like this. Repeat after me. Che che kule. Che kofisa. Kofi salanga. Lala tilanga. Kum adene. Kum adene. Wow. Give us a big round of applause. Cheche Kule is one of the songs we used to play, especially, it's like a folk song. It's similar to head, shoulders, knees, and toes. So you're going to repeat after us with some soft, nice, gentle music, and then we see. So we go. Che che kule, che che kule. Please, I can't hear you. You see, when we go to British Got Talent, for example, I said, this is our team, this is our group, we're coming to do call and respond. And I say, che 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 kule, che che. Simon Cowell will say, please. So please, give me the energy. Che che kule, che che kule, che kofisa, che kofisa, kofisa langa, kofisa langa, lala tilanga, adene. Welcome, Shadrach. Eke Tetelasa. Kecha seka kecha bli bli, bano ba ego, ala nula ego, bano ba ego. Ega banuego, ala nue, banuego, banuego, ala nue, banuego, ala nue, ala nula ego, bano ba ego. Now welcome, boom style, sharp one, Van der Sar. Let's go. All right. My name is Emmanuel. This is my junior brother here, Enoch. And this is my son, Albert. And this is my friend, from Ghana. A big applause. Also, we are available for all kinds of events. Like I said, if you want our contact numbers, please see Faye. Okay. Faye. She invited us here through a friend called Kenny, all the way from Ken. It's a short notice, but we try to make it. Thank you very much. I'll see you.
Thank you. Put your hands together. Come on, let's give it to them. Brilliant. I can see you all fired up, ready for the afternoon session. That's the way to do it, isn't it? So thanks, guys, for coming at very short notice. You know, yeah. Brilliant. So we're going to kick off the afternoon. For those of you who may not know me for the first time, my name is Charles Kwakodre. Absolutely delighted to be the Chief Exec for the Caribbean African Health Network. And what excites me and drives me 7 days a week is your support. So put your hands together for yourself. Great to see you all. Well, earlier on in the morning, some told me, oh, I didn't know I was coming to a really nice place or a big event like that. So, you know, it's great to have you all. And I think that's what makes a lot of difference. To kick off the afternoon, we did invite, sometimes we do things at really short notice, but because it has to be done. And is there ever a good time? Sometimes you plan, sometimes you pull things off so quickly. So don't forget, before you leave today, we're launching the Black Healthcare Awards, 27th of July at the Westminster, Park Plaza, Westminster Bridge. So I shall look forward to seeing you there. 1,200 people could be there. So it's one of the premium places in Europe, not just in the UK. So you can't afford to miss it. If this was good, if today you've heard from amazing speakers from our community, from beyond, then please, please put someone forward, a Caribbean or African clinician that has done amazing work. We want to raise their profile. Why do we want to do that? Since the 2nd of May 2020, every Saturday on the Health Hour, we have a Caribbean African doctor who presents on Zoom. We live stream to YouTube and Facebook. But then when we look in the mainstream media, we don't get to see our people. So we said, let's get the award launch. And you saw Vishal here earlier on. I was at Google and said, what can we do with yourselves? So the award is coming on live and colored. And please make sure you put someone forward. Thank you very much. So, we did also put a call out for posters, and there were 5 excellent quality posters that have been doing some brilliant work with the Caribbean and African community. So we're going to hand, some certificates to them of recognition before we invite the wonderful Professor Bola, who, and among others, have given their whole day. If we had to pay them, as charities, we don't have any money. And all of you have had some free food. So if you want to make a donation, please do that before you go. You're more than welcome. But they've given their time, and she's going to kick us off this afternoon with a keynote speech, but then other amazing ones, and then some workshops upcoming as well. But to kick off with the certificate of recognition, some of you know about allyship, and I'm going to call on the stage to hand out the awards. He is a fantastic patron for Khan, and he's not just patron in words, but he does support financially, and we are ever so grateful. But he's come all the way from Greater Manchester. He is the Vice Chancellor and President of the University of Greater Manchester, also one of the Deputy Lieutenants for the County of Greater Manchester. And Professor George Holmes is here to hand out the awards. So he's going to come on stage, and then I'll call the winners. But let's make him welcome. Yeah.
When Charles invited me here, he didn't tell me I had to follow that type of performance. I mean, it's just phenomenal. But give me a few minutes, I'll go get changed, okay? Give me a few minutes, okay? That's great, okay. I'm delighted. By the way, my university is University of Bolton in Greater Manchester. Slight typo on the document there. But we are so delighted to be principal patron, both myself and the university, of this amazing work that we're doing. And our new medical school that's opening will be all about encouraging the widest possible participation in medicine and training for medicine, and particularly... And particularly, we understand the importance of training doctors who fit in with the communities that they're looking after. That's absolutely critical for us. And so that'll be a central part, which is why Charles and I and Faye particularly are working on this particular project together. So delighted to be here today. And as I say, let me get my costume a bit later. All right. Yeah.
Brilliant. So I've been told we are behind time, but I know you forgive me because I gave you a longer time to enjoy the performance. So the first person to receive an award, it's a project that is promoting eye health and research in underserved communities. It was a partnership between local charitable government and faith organizations, including Ascension Trust, Hounslow, Lambeth Borough Council, Black Majority Churches, and Croydon Swagna Temple to present eye workshops and research seminars on eye conditions. And to receive that is Dr. Roseanne Crosby Inwabi. Dr. Roseanne. So if you haven't seen any of the posters, then at the end of the events, please go to where we had lunch. The second project is development of a dietary resource for African and Caribbean patients requiring low potassium diet. And it developed the resource for patients. They did diet sheets, accompanying multicultural handbooks for dietitians to increase their understanding of how to advise on low potassium in the context of multicultural diet. Deepa Kariyawasam. Thank you. The next is Research for All, Research for You, a short engagement film planned for pregnant women from ethnic minority groups, encourage them to take part in research studies. To receive that is Michelle Anderson. Are you here, Michelle? If not, we will hand that later. Brilliant. And then last two, Enfield Breakfast Town Hall meetings. This is from Enfield Council. They had a local partnership with, NHS organizations and Revival Christian Church of Enfield to deliver a series of community events coined the Breakfast Town Hall. To receive that is Riyadh Karim and Louis Butler. Oh, yeah. Yeah, Pastor Nick, if you're here. Yeah, but if not, we can do the photos outside. We've got a banner out there with the Inspire logo, so please make sure you do some photos for social media as well. Oh, Pastor Nick, yeah, you join quickly.
Is it trusted places, trusted people, trusted voices?
Yes, yeah. Brilliant. And last but not the least, the nerve of my multiple sclerosis. This study delves into the enrollment disparities in Black patients in MS research, particularly focusing on inclusion of 456 Black individuals diagnosed with RRMS. You can tell I'm not a clinician. And primary progressive multiple sclerosis. To receive that is Natalie Diana Busari. Okay. Thank you very much. We shall pass that on. Thanks. Yeah.
He just said get off, didn't he?
No, not at all. Brilliant. So the next keynote speaker needs not much introduction for some of us, but she's an amazing person, really supportive ever since. Oh, Professor George, your seat is waiting for you. Or you're going to get changed. Shall we welcome the amazing Professor Bola Owolabi to give us the keynote speech for this afternoon.
How do you follow that welcome?
You're all very kind. Thank you so much, Can, and the organizers of this event, Charles and colleagues. Thank you again for inviting me to once again, share the platform, I believe, with you all in terms of the work that we're doing together. It's such a pleasure to be here. Lots of warm hugs already, even before getting on the stage. And can I just start by saying thank you so much to you all for the work that you're doing in your own spaces. I'm very mindful that not everyone necessarily gets a stage, but I do believe that actually the progress that we're making is not necessarily because of those of us who get to be on the stage, but many of you who nevertheless continue to push forward. So to you all, thank you. And many of you will have heard me speak before. And sometimes people say, do you never get tired of saying it? But I took comfort from something a leader said to me once. When you've said it 1,000,000 times, there are those who've heard it for the first time. And that's the reason why you must never tire of saying it again and again. And so for those who have heard, do please bear with me. And for those who this is your first time, I hope you'll come with me on what I hope is a conversation of hope. Because ultimately, that is the job of leaders, is that we are sellers of hope. All of us can talk about how incredibly difficult and terrible things are. And this is not to diminish that fact, but I do believe that one of the powerful jobs of a leader is to instill hope, nevertheless. And that's why I always start with this vision statement, that I believe what we are all gathered in service of is to get to a future horizon where we can say that we do have exceptional quality healthcare for all, and for all to include communities at the margins, those with little or no voice. And that we achieve that by being mindful of these 3 dimensions: the equity of access, not equality of access. It's about the equity of access. Some people need extra benches to see over the garden fence, for those of you who have seen that graphic. So it's about equity, and to be mindful that when you already suffer disadvantage, your experience matters even more. And hopefully, if we can achieve that equity of access and the best experience that we can afford people, regardless of who they are, that is how we then achieve the optimal outcomes, which I believe is the reason why everyone in this room is here. And the Race and Health Observatory have done a powerful job of describing this in pictures. I'm a big believer in a picture speaking 1,000 words. And you don't need me to call out each one of the specific data points in this graphic. I commend it to you for those who haven't seen it. But I will call out some, perhaps because of personal experience. And I'll start with the maternity one. You've all heard it, but let's say it again. That Embrace have been telling us for many years that Black women are 4 times, it was 5 times, it's come down to 4 times, but 4 times too many. 4 times more likely to die in childbirth or the year following delivery compared to their white counterparts. Let's talk about cancer. We talk about prostate cancer, that 1 in 8 men in their lifetime will develop prostate cancer. But for a Black man, that is 1 in 4. So it's double the risk. And I just wanted to call out those 2 specific data points to make a wider point that health inequalities are not a conversation about data, strategy, and policy. It's the lived reality of many people across the country. I call out the maternity one because that was me 21 years ago in a side ward, on a labor ward, first pregnancy, forgotten for the entire duration of my labor. I monitored it myself because I have the benefit of a medical education. That's not necessarily the story of the 4 times more likely to die. And you look at our patient safety reports. We talk about people who died because their first language is not English. We talk about people who have been excluded because they can't afford the smartphone. And we talk about the people who have died because we've overshadowed them with their primary diagnosis. And if the money we pay out in claims every year when things have gone wrong, if we reinvested all that money in frontline services, I think we will be better served. This slide is to make a point that health inequalities don't just cost the individual and the community. It's costing the NHS. And if we didn't make a move just on the pure moral and ethical grounds, surely we should be bothered, because this is costing our National Health Service as well. But I very quickly pivot from the realities of those data into the so what. I think it's really important that we all find our voice in the so what space, because there's a danger that people have heard the problem so often that there is a risk that we develop antibody, unhelpful antibody. And so let's talk about the so what. How do we narrow the gap? And I'm sure that we can have many a conversation about this, but I offer up my reflections a few years on this journey across these 3 dimensions. I think there is something about the sophistication of data. You remember in 2021, and I'm going to embarrass Professor Fenton in a minute, in a good way. You remember back in 2021, when many people said that the COVID-19 pandemic is the ultimate leveler. How many people heard that turn of phrase? But of course, the COVID disparities report, led by Professor Fenton, came out in June. And that data showed us that the pandemic was absolutely not a leveler. We all weathered the same storm, but we did not weather that storm the same. And I'll say it again, that many people weathered the storm in cruise liners. Others had leaky boats, and still others had no boats at all. And what that COVID disparities report did was to tell the same story, but with data. And therefore, my call to action, first of all, is for us to become sophisticated with letting the data tell the story. Ethnicity coding. It's a clarion call that ethnicity coding is still not where it needs to be. And so what that does is when you disaggregate data, people will say, but the underlying data is not complete. Can I ask each one of us to leave this room and talk to our communities? If you are not in the data, you don't exist. And if you don't exist, the resources won't travel towards you. Let's get this right. Data disaggregation. Every time somebody presents aggregate data, be the one in the room to ask the question, if that data was cut differently on the lines of ethnicity or deprivation, how does it look now? Because we all celebrated the fact that, the uptake rate of the COVID vaccine was 82% in January 2021, and that was world leading. It was world leading. But when you disaggregate it, it was 38% for Black Africans, it was 44% for Pakistanis, it was 45% for the 20% poorest people. I've said it many times before, and I'll say it again, that there is a tyranny of the average, because absolute data hides the reality of inequalities, data disaggregation. Be the person in the room that is asking the question, what is the actionable insight that this data gives us? Because the other thing I find is when data becomes an end in itself, where it becomes a diversionary tactic to talk endlessly about the data and never get to the point of what is the insight that this data is showing us. Because in the absence of the insight, we will forever be paralyzed by the analysis of the data. So be the person in the room asking, what is the actionable insight? And when you get the answer, let the next question be, and what are the interventions we're going to put in place? So when we spoke to the imams and the pastors and the leaders of other faith groups on the basis of that vaccine data, the intervention they gave us was, our people don't go to golf clubs. Stop putting the vaccines in golf clubs. We can administer them in church and in the mosque and in the gurdwaras. And that intervention from the actionable insight led to vaccines in places of worship. And you saw the needle move from 38% in January to 70% by July. That is the power of forcing the conversation to move from data as an end in itself to a source of actionable insight. I think there is then something about using that to leverage the point about equity of access. So many drug companies want a meeting with Bola. And I always ask them, how do you know that your novel therapeutics are reaching the populations at the peripheries? It's all very well increasing the investment into those under the bell curve. How about those on the either sides of it? Equitable access. And ultimately, for whatever intervention we do, what about building a retrospective look, a health equity audit? Did it narrow the gap? Did it widen the gap? Or did it leave it exactly the same? These are the dimensions that I think we need to become more sophisticated in. What about having a framework for action so that we do what Rob Webster says, we stop admiring the problem and actually do something about it? And to do that requires leadership. And I put it to you that every single person in this room, you are a leader in your own right. So rather than waiting for those who have the opportunity of speaking from the stage to do something, how about we all do something? It's about courageous leadership. And courageous leadership means leaning on others. It's not about independence, it's interdependence with others. Use days like this to find people to give you resilience, endorsement, validation, encouragement that what you're doing matters and that your value, your contribution does matter as well. What about policy and regulation and intentionally influencing policy? So, for example, we've recently had a call in terms of the long-term mental health plan. How many of us responded? What about the cancer long-term plan? How many people in the room responded, and our organizations? We've recently had the GP incentives consultation, how GPs will actually be incentivized for the work that we do. How many of us responded? I think there's something about intentionality of effort beyond the rhetoric. And also thinking about regulation. You know, when the CQC is designing its single assessment framework and calling for evidence of what to consider, have we responded? That it shouldn't be tenable for an integrated care system to be rated as outstanding if they haven't got a cogent, evidence-based story of narrowing health inequalities. What about the conversations that we can have with the GMC about the equity of opportunity regardless of people's background? What about the conversation that has been kicked off by the Race and Health Observatory on the basis of equity in medical devices and the work that the MHRA is now doing in that regard? How about research? You know, when we think about whose voice gets heard in research, the composition of the grant-making panels, clinical trial participation, increasing the grants to make sure that they can build in the effort, the additional effort it takes to reach those at the margins. Who decides where the research is done? What about the North? What about the Midlands? Excellence exists in the Midlands, right? It's not the purview of London alone. How about innovation? You know, the representation of innovators. Have we looked at that? The innovation pipeline. When we choose to fund innovation, do we ask the equity question? Representation. Not as a tokenistic activity, but actually an intelligent decision. As the Harvard Business Review told us, that the best boards are the ones that reflect the market, because they're able to bring the market perspective. And for organizations for whom the bottom line is important, they recognize that diversity on their boards is not a tokenistic gesture. It is a financially literate decision. To not have diversity and representation is actually financially and economically illiterate. And this is the sort of conversation that we need to have, that it's not about people being at the receipt of our kind benevolence, but that actually representation is a very powerful force for our own organizations to thrive. We are not bereft of policy. This slide is to make the point that we are awash with policy. The question is, so what? How do we pivot from policy into practice? For those who are clinicians in the room, I put it to you that clinical leadership is incredibly powerful. People do still trust their clinicians. Your voice counts. What you say counts. And I think if we consider that actually this is a marathon, it's not a sprint. Not necessarily everybody in this room will be here in 20, 30 years in the same role. But I ask you, what would your legacy be? How will you have used your voice? What would be said about the use of your voice in service of the voiceless, for the sake of those at the margins, and in arguing for those at the peripheries? We are not lacking in a framework for action. Most people would have heard about Core 20+5. It is not the sum total of the answer to health inequalities. It is not a panacea. It is not a silver bullet. It absolutely is an excuse remover, because it stops us from saying we don't know what to do. It stops us from saying we don't know where to start. If we don't know where to start, let's start with a focus on the Core 20+, who do include our Black and ethnic minority communities. Let's start with these clinical areas driving the greatest inequities in mortality and mortality differences. What about children and young people? What about the 10-year-old who died as a result of air pollution exposure for her severe asthma? The coroner said that is the cause. And that is why asthma is on this list for our children and young people. What about being part of the ecosystem that turns Core 20+5 from a pretty infographic into something meaningful in people's lives? And it's great to see some of our ambassadors and connectors in the room. Maybe we should all ask ourselves the question, what is my role as part of the delivery ecosystem for Core 20+5? I'm going to very quickly talk about cause for optimism and hope. Sickle cell. Maybe the best message I've had in the last 1 year is somebody on LinkedIn who said, ever since you started making a lot of noise about sickle cell, that's how they put it, The way that I'm treated in accident and emergency has changed. And they even offered to come and work for me for free. But you know, in terms of the hyperacute units that we've set up so that people are not parked in A&E in absolute excruciating pain, making sure they have access to those specialists and those analgesia that is so time critical, making sure that people don't have to repeat themselves over and over again by having a digital care plan, and so many things I can talk to you about. What about the work that we've done with our Small Business Research Initiative colleagues who have invested nearly $1 million in maternity health inequalities over the last year? How about the work we've done with the National Institute for Health and Care Research, NIHR, who now have the Include framework to do exactly what we were talking about earlier, to better represent the community that we serve in our clinical trials design and recruitment? How about the nearly $4.2 million that we invested last year for the academic health science networks? They're now called the Health Innovation Networks. Asking them the question, for NICE approved products, why is it that the uptake in Black and ethnic minority communities is not what it needs to be? For example, inclisiran, it's a cholesterol lowering medication. And when we looked at the data and the uptake, it was dismal in Black, African, and other ethnic minorities. And yet, you look at who gets stroke and heart attacks, they make up the majority. The inverse proportion law, again. And finally, I just want to say that the reason I've ended on that note of what is already happening is because I want you to leave this place feeling enabled. I don't want us to leave feeling despairing, that it's all so enormous and complex and nothing is changing. I want to encourage you that a lot is changing. There is still a very long road to travel, but actually what will continue to make the change happen is every one of you sitting in this room and the spheres of influence that you occupy in your private lives, in your professional lives, and I'm asking you to join me in being the what about brigade. Every time somebody presents the data, what about? The research, what about? Innovation, what about? We're going to make this investment and this funding, what about? Be the what about the brigade. Thank you.
Wow. Thank you very much, Professor Bola. I will not attempt to summarize. What about? Pleasure is mine to, please, if you're leaving for the day, make sure you give us some feedback, honest ones though. The pleasure is mine to invite another, really important person and actually my boss. And it's a PhD that started the organization, but we're really delighted once again, the way Khan works, the way Inspire is meant to work, it's all about collaboration and partnership working. So 2 years ago, we had the opportunity, or we're asked to convene the first National Black CVD Advisory Group on behalf of the National Clinical Director. So, Dr. Faye Ruddock is the chair for Khan, but she also had to chair that commission, so she will share a couple of thoughts with you. Can you make her feel welcome?
Good afternoon, everybody. So thank you, everyone, again for being here. And I'm just delighted that we've got such a fantastic audience for this first Black Health Summit. And it's always the way, isn't it? It's like Averta said this morning, how could she follow Kevin? It's like me this afternoon, how could I follow Bola? but I'm here in my own right in terms of looking at CVD, a real passion of mine, which actually started in 2013, where I did a piece of work which looked at the PCT, which if anybody's been around long enough to know about the Primary Care Trust, I looked at why is it that black people are still having the poor outcomes from cardiovascular disease, particularly hypertension, stroke and all of that. Why are we still having this conversation where the data is still so poor about black health outcomes on that? So what I wanted to do is talk to communities. I'm very, very much about communities, hearing community voice. I always have been. I was very, very much one of those individuals that grew up in a church. My dad was a deacon, if anybody knows those terms. My dad was a deacon. And very much what I saw happening around me were people dying early from strokes, amputations, and all of those health issues, diabetes, and you name it, they had it. And I was really worried. What was going to happen to my dad? What was going to happen to my mum when I was little? And I just wanted to do, I became a nurse, and I then just said, look, I'm looking around me and I see inequity. I see things are not fair. I see people are not treated well. I wanted to go in there and do something about it. And then I moved into universities because I wanted to be, you know, we always say nursing, see one, do one. And that kind of way that people practiced was not what I wanted to do. So I wanted to get into university to teach people how to do things better. So that very, very much led to this master's programme around CVD, looking at the outcomes, finding out actually that people, even though we had all these poor health outcomes around CVD, nobody was talking to the community. Nobody was finding out what was the issues, what were the challenges. Nobody was talking about prevention to the communities. So you can't find out all of that and leave it. Went on to do my doctorate, followed the same trend, but community was telling me it wasn't just about CVD, it was about everything. All the health issues, the same issues around trust, around no voice, around racism and discrimination, all the things that have been said this morning. This is what the doctorate found. And then, of course, Khan was developed out of that PhD. And I'm really pleased with the way that it's gone in terms of it being an infrastructure organisation, a real template for change. And that's where we just want to see so much more collaboration, so much more partnerships. And as people say, you can't do it on your own. So it's very, very much about how we collectively come together to change those outcomes that we're actually seeing, because we are the change. We know what changes are needed to happen. And this conference is all about recognising that, but it's about action and what we actually do next. So I just want to go through a few slides, and then I'm going to hand over to Julie, who was part of the CVD advisory group that I did chair in collaboration with NHS England. So if we just go... Okay, so I'm not going to go through all this because every presentation this morning has talked about all of these issues, and it's really good because we're all saying the same thing. We all know what the problems are, so we know what those issues are. We know CVD is a huge burden, an economic burden, and I often say, if it's this burden, economic burden, why aren't we doing something about it? It actually makes common sense to do something about it. So this is what it's costing us all as taxpayers. So I've talked a little bit about the timeline, and just fast forward to 2021, where we did some policy school sessions looking at how and what the agenda should be around health inequalities. So we did some presentations there, and from there, that's where we got involved and looked at the creation of the CVD advisory group in 2022, and we brought together all of the different people that would enable us to reach some solutions to CVD. So we collectively worked with people with lived experiences, we worked with clinicians, we worked with we worked with everybody that could have a voice around this. And we call ourselves the engine room, where we actually drive some of these changes. And so currently at the moment, what we had was, as an outcome, was looking at the policy paper, which is being drafted now, and we're hoping to launch that policy paper this year. Bola has mentioned about some of these levers already, and they're all there, and Core 20+5, and I always talk about Core 20+5 because it's a real one where we actually get lived experience connectors working with primary care networks to actually change how do they treat, engage, bring about solutions, clinical pathways with our communities. So we have them in Greater Manchester. We're very, very much part of that Core 20+5. And there are all these different programmes that do exist. Some of the key themes, again, some of them have been mentioned this morning. Bola's mentioned some of them, but from a VCSC perspective, one of the issues is around looking at the hyperlocal response. We know places like churches, we know community centres, we know that there are lots of assets, community assets, that are actually based within those spaces. We've done an awful lot since 2017, going into churches, going into barbershops, going into places where we can actually skill people up to actually be able to monitor things like hypertension, get people to know their numbers. Funding and capacity building for the VCSE, for those that are VCSE, and it was mentioned this morning, we had a really great session around CVD in the breakout. And we talk about things like the funding, short-term funding, what can you do with that? And often we find ourselves, if we're on a short-term project and it's working very well and we have to stop it, what happens to the people that are part of it? You know, especially when you've got people, connectors, giving up their time, really passionate about what they're doing, you've educated them, the funding stops. You know, it's not really, and we become not the trusted people because we've brought them on. So we've really got to think about this idea of projects need to come to an end. The racial health inequalities, the training, we know across Greater Manchester we don't have the right education and training around racism, anti-racism, cultural competency, it's not there. The role of people that are already trusted, we need to utilise them more. Health literacy and digital inclusion, very, very, very important. We've mentioned this morning about our health hours that we do every Saturday. How do we empower people with information, with knowledge? And also not oversimplifying us as one community. I mean, probably in this room, as Black people, you know, there's probably many, many communities within the Black community itself. And again, you know, Professor Kevin Fenton and others have talked about racism, but benchmarking for me is a really big thing as well. How one size doesn't fit us all. Really, really important that that these are the themes that came through some of our conversations. We need to work differently. This conference is all about working differently. It's utilising what worked through COVID, and we were very, very much part of the COVID-19 vaccination programme. The very first time we saw NHS England going into churches and doing things, you know, and it's like somebody said this morning about, you know, where are, you know, hard to reach. And I always say, if you go into a church on a Sunday morning, you'll find hundreds of us in there. We're not hard to reach at all. So, you know, that vaccination programme is a real template. And what we said to NHS England is, just because COVID is still there, don't leave us now. You know, we need this model to be scaled up and to use that, because that is a model that actually worked. But proper investment, I've talked about, policy frameworks as well, co-creation, co-production, working with the ICSs and system partners to make the changes that we need to see. And I just want to bring in Julie, because Julie was part of the CVD advisory group because of the lived experience. You're going to just say about the importance of actually being part of that CVD advisory group, and then we'll finish with the recommendations.
Thank you. It's something today. I spoke earlier about my lived experience of CVD, lupus, being obese, having mental health difficulties, but still like working within the NHS. And I just want to repeat that a little bit, because just being on the CVD group of NHS England, which Bola, Faye, Charles, all sat on and Bola led it. It even opened up my eyes to the fact that I was being discriminated against in some way or form because I wasn't getting the services that was actually Bola was talking about, Faye was talking about, Charles was talking about. Where were those services? And I'm somebody that reads policy. I'm someone that's quite educated when it comes to health. But I didn't know about a lot of things, and I think that my journey since then has been around making sure that I can spread the word to different communities, not just African Caribbean communities, but brown communities too, people of Asian, South Asian, because we're in it together. We are in this together, but I know how important it is just being part of the patient involvement panel of the CVD group, how important it is just to listen, learn, share with you all. And, you know, I could get emotional now, but I won't. I just want you to know that it's not been emotional, it's actually been a learning process for me. I can't stand here and say to you that, you know, I'm well and I'm able and, you know, but I think that, like what Bola said, you know, there's some of us that need a few other benches to pick us up a bit. And I think that, and sometimes we need that extra hand. And it's important that we recognise in our communities there are a lot of disabled people too. A lot who do not identify as being a disabled person, okay, but who live with long-term conditions that are very disabling. And I think that you really do need, as a community, to really recognise that and really bring it home to our communities that there's help out there, but sometimes we've got to force that help. We really have to push. I know you're doing it all already, but there's more to be done, and we can do this, but together. Thank you.
So just to finish off, thank you, Julie. Some of the recommendations for the policy position paper that you'll see will be circulated. Again, very, very much what people have already said. Bola's mentioned about the data, really important. Referral pathways, leadership management. There's so many things that we've had synergy around that we need to be looking at. And then we've got this call to action. Professor Kevin Fenton talked again about that anti-racist framework, you know, looking at the infrastructures. What we need to do as well is target younger people. We need to, you know, one of the things I've always had a bugbear about is the health checks at 40. You know, I say, if you look at black people are getting hypertension in their 20s and 30s. Why are we not having something that targets us earlier? So we need to look at how we can get those educational messages and interventions earlier. Using the CVD advisory group as a template, because I say CVD is emblematic of a health inequality. You can use it for anything, prostate cancer, all of those things have been mentioned. We want to look at how we can scale that up, and also looking at the responsibility and the accountabilities of the ICS as well, looking at the partnerships. You know, how are they actually putting the investment in to enable us to reduce that CVD in our communities. So we want them to be built into 5-year plans. We don't want short-term money. We want proper embedded into those policies and practices. So thank you, everybody, for listening. Thank you.
Thank you. Please put your hands together for them. I know we're running behind time, but we'll do some magic very soon. So pleasure is mine now to invite another amazing woman, Yvonne Cargill, CBE. Oh, please make her feel welcome.
Oh, thank you. Do you know, this is chicken soup for the soul. Being with all of you guys is just wonderful. Having the opportunity to sit with NHS royalty like Bola and Habib, and Kevin, and there's Evie in the audience and others. It really does my soul good. I mean, those of you who know me will know that I started in the NHS back in 1977. And I retired in 2020 after 43 years in the NHS. So, it is with pleasure that I attend meetings like this. And I want to thank Charles and Faye and Sedi and everybody else who has invited me along today, bearing in mind that I am no longer in the system. I can say things. Things that really, really others cannot say. My slot is about a call to action. And I was saying to Habib, we got the wrong people in the room. You guys know the issues. We know that discrimination in our NHS costs money. We know that for every one standard deviation point of increased engagement in an organisation, it saves £1.7 million. We know, because we have the data that tells us this, that discrimination of our staff causes poor patient care. I can remember when Jeremy Dawson and Michael West put out a paper back in 2009. And it actually said that. It actually said, for every Black, Asian and minority person that's discriminated, patients will get poorer care. And I thought, hey, fantastic, wonderful. All the chief executives are going to read this and things are going to change. That was 2004, right? So here we are in 2024. So I'm going to quickly whip through this because I know that you guys are waiting for your tea. And so here we are. I'm supposed to be doing the getting you to pledge. I'm not getting you to pledge anything because I think you guys know what needs to be done. And I think the people who need to be in this room are the Amanda Pritchards, the Chris Hobsons, all of those people who really need to take note of what is going on here and what is being said. I wrote this a while ago, and many of you will have seen this already. This is what we're dealing with. We're dealing with a complex, sophisticated, and highly successful system. Why is it successful? Because it's been in existence for how long? Forever. Over 400 years. And it benefits those people sitting in positions of superiority. It benefits them for the system to be as it is. And the system is sustained by the attitudes and beliefs and the behaviors of those people in power. So the issue is, how do we get them to change? What is it that we need to do? And we need to start higher than those people in the NHS. Because we have a government here, and I haven't heard anybody talk about this yet, who has moved so far to the right that we're falling off the cliff. We have black people in government, and people say we've got black people in government. We have brown people in government. Isn't it wonderful? But some of those black women say things that would make your, well, I was going to say make your hair curl, make your hair straight. You will all know this woman. How she's standing, I don't know. This woman has been through hell. Not just this last debacle that we've had. I remember Diane Abbott, back in the day, having to run the gauntlet. The things that are said about this woman on social media, I don't know if you guys read this stuff. How she is still alive, I have no idea. But I put her up here because last week, when all this was happening, 2 weeks ago when this was happening, it hit me in the chest because I am her and she is me. And I remember I put something on Twitter probably about 4 years ago about Meghan Markle. And guess what? Piers Morgan responded to my tweet. What did he write? "You are racist," is what he wrote. All of his trolls, thousands of them, piled in on me. And I had that for 48 hours, and it was excruciating. This woman has it day in, day out, for years. I think she deserves more than a bloody medal. I genuinely do. So, some of the people who've spoken already have stolen my slides, but that's okay. So I'm going to whip through them as quickly as I possibly can, because I know you're waiting for your tea. We know all of this already. You know that if you're black, and I'm not talking brown, I'm talking black. If you're a black African or African Caribbean, you are at the bottom of the pile. The data shows that. You have a worse experience than anybody else in this country, in this world. We know, we can see what's happening in Haiti, and that hasn't happened by accident. These things do not happen by accident. Bola showed this, and I think it's a fantastic slide that Habib and colleagues put together. Spend some time looking at it, because it really hits home about what the issues are for us as black, Asian, and minority ethnic people in this country, and what it means. I go back to my point about senior leaders in the NHS, senior leaders in government knowing this stuff. It's not a secret. It's out there. So the question then is, where is the empathy? Why aren't they doing anything about it? And it's a question that I keep asking and not getting very much in terms of an answer. I've been very fortunate. I've worked with the wonderful David Williams at Harvard University. I don't know if any of you have heard him speak, but if you haven't heard him speak, look him up on Google and listen to his talks. He is phenomenal. He's been working on health and race all of his life. And he, myself, and some others did some work, probably about 4 or 5 years ago, about what it takes to change the system in the NHS. Because one of the questions that I'm constantly asked, or was constantly asked, what do we do? I don't know what to do, Yvonne. How do we make a change? What do we do? It's not rocket science. All the people that have spoken have mentioned all of these things. They've mentioned visions. They've mentioned leadership. They've mentioned data. They've mentioned targets, responsibility, accountability, communication, resources, and then celebrating. These things put together in an organization will change it. And we used to, Habib and I, used to go out and about in the country talking about race inequality and so on and so forth. And, you know, we did the race equality, workforce race equality standard work. One organization in the whole of the NHS, one, that was moving the dial in the right direction over years. Habib will know the name of this organization. Does anybody else know the name of the organization? One. North East London Foundation Trust. Why do you think that happened? It happened because the chief executive at the time, John Browder, made it his business to change things for his black, Asian, and minority ethnic staff. So every year, year on year, the data was changing. I don't know what the data looks like now, actually. I have no idea, because John left a few years ago. But he put his backbone into making it different for his black, Asian, and minority ethnic staff, because he knew that if his staff were motivated, if they felt cared for, if they were appreciated, guess what? The patients would be getting a better experience, because we have the evidence to actually show that that is the case. This thing that I wrote a few years ago as a consequence of making things different and making things happen because Dr. Williams and others had done some work around it is evidence-based. So ask yourself, why don't we do it? I wrote this as well. This is the 8 A's of allyship, and I'm not going to go into it in depth and detail, but this is what we need our white colleagues to start thinking about and do. We need them, and we really do, to appreciate and to value what we go through, to empathize with what we go through, to ask the questions about what we go through. I don't need any of you to be asking these questions, beautiful and wonderful that you are. I need the senior people who can make a difference in our organizations, in our government, in our country, to start asking these questions and to actually think about what it means to lead 26 point whatever it is people in an organization like the NHS from Black, Asian and minority ethnic backgrounds, and how can we make sure that those people feel valued and appreciated and so on. Allyship is absolutely key, and I don't even know if you want to call it allyship. Being an accomplice in all of this is probably more to the point. So I'm coming to the end now, because I know you want your tea. But actually, this is what I've been asked to do. I've been asked to get you guys to pledge, to get you guys to do something, action, in terms of this agenda. So these are things that I came up with, and others have already mentioned these things. You need to understand the complexity of the thing that we're dealing with. You need to be able to articulate it properly when people come up with the, well, what about? Because the whataboutery is out there, and you hear it all the time. Well, what about women? Well, what about disabled people? Well, what about? And somebody earlier said it. If you get it right for black people who are sitting at the bottom of the pile, you will get it right for everybody. Yeah? Talk about this stuff with confidence. What they want to do is shut you up. They don't want you to talk about it. They want you to talk about EDI. I absolutely refuse to talk about EDI. I talk about race. And when people say to me, you're an EDI expert, that's equality. I don't talk equality, I talk equity. Yeah? The NHS is already very diverse, so I'm not talking diversity. But we do need to talk inclusion. Inclusion is key, and we're not there yet. Habib showed a slide where we saw that the Black, Asian and minority ethnic staff are sitting at the bottom of the pile, and actually, white staff are still sitting at the top of the pile. You go into any organization in London, and you'll see 1 or 2 people who look like me, maybe, but on the whole, it's people from white middle-class backgrounds, and that has to change. So you need to be able to talk about this thing with confidence and explain to people why it is that it's important for people like you and me to be in positions of power and authority. I tried for 5 times to become a director of nursing. I've got the stage now, so I'm saying it. Nobody would have me. I never became a director of nursing. I was just never good enough. Yeah? So here we are. Insist that your hospitals and your groups have leaders that demonstrably show you that they are making a difference. Not just words. I'm fed up with words. I've heard the words. Find out what your MPs are doing. What are they doing about all of this, apart from sitting there and bringing in more black and brown people who will say what they want to hear? Yes? You don't hear people like me sitting up in Parliament. You don't hear people who are going to be saying the things that they don't want to hear. So find out from your MPs what it is that they're saying, what it is they're doing. Make sure that you are out there making a noise. Because if you're not going to make a noise, things will stay the same for the next 43 years. And somebody said there's all these lovely young people here, and I'm seeing them, and it's fantastic and wonderful. People like you guys have to take the baton and run with it. So the pledge that you need to make is actually get out there and keep pushing that agenda so that we break down the doors and the barriers and get to where we deserve to be. Thank you. Thank you.
Thank you, Yvonne. So please follow Inspire on social media and tell us what you're going to get out there and do. It is time to go into workshops. For those of you going to other breakout rooms, there will be drinks over there. But I need you back at 10 minutes to 4 o'clock for our final plenary. So please follow us on Inspire and tell us what you're going to get out there to do. Thank you very much. See you at 3:50.
directing people to the right services, that proportion of young black men having that initial experience in their mental health services has been dramatically improved. So there are some examples of really good collaborative, meaningful work going on, but there is so much more to do and so much we need to build on. So it's fantastic to be invited to be part of this discussion today and to listen and learn and take back everything we can from these discussions.
Thank you so much. I just want to say to everyone on the panel, including myself, that we just need to speak a bit louder because apparently people can't hear us at the back. But yeah, over to you now.
Okay, I'll try. Can you hear me now? Yeah, has that one worked? Okay, that's good. Okay, I'm George, and I'm the head of the university in Bolton in Greater Manchester. And the reason I'm here is that we are mega supporters of the Khan operation. Thank you. So each year we donate over £100,000 to that particular charity with the view to helping inequalities be addressed, particularly in terms of health outcomes for the communities that are close to our heart in Greater Manchester. We are forming, the reason I'm here is we are forming a brand new medical school. It's really good that I'm in the Royal Society of Medicine today with this, on this agenda, because we have the GMC, the General Medical Council, coming to us in the summer this year to sign it off. And it is like no other medical school because it's backed by Khan and it's about social justice in medicine. And it's about levelling up outcomes properly in terms of health inequalities, and particularly for the groups that we're talking about here today. And my strong view, my oldest daughter is a junior doctor, a surgical registrar, and my strong view is that in training in medicine, there is not enough inclusion of communities who need to be represented. And our medical school is going to be about that in terms of ensuring that happens with the assistance of Faye and Charles and colleagues to get students to get into communities and achieve potential so that individuals can recognise that they can enter a medical school of our nature. They can then develop their own skills and expertise so they can stretch out to communities, reach out to the communities they live in and work in, and allow communities to believe in them. But more importantly as well, to train doctors who are alongside them to understand the subtleties and importance of the different patient needs from different communities and different groups. And so this is a medical school that's about social justice. It's probably the first medical school for social justice in the country, and that's vastly important to me, and that's why I'm here today to talk about it.
Thank you so much to each and every one of you. So yeah, we have our panel here and we're going to dive right in. So obviously today we're going to talk about creating sustainable change in Black health. So my first question, any of you can take this question. I know that many Black Londoners will feel that obviously racism plays a huge part in inequality. So how much of a part do you think that it plays in each of your roles, and what are your organizations actually doing to tackle that? Do you want me to just pick someone, or? Okay, you pick someone. Okay, you, George.
Well, we've invested £50 million in this particular medical school, and as a classic illustration. And it's sustainable, isn't it? It's long-term sustainable overcoming of the prejudice, of the injustice, on the inappropriate behaviour of society, really. And it's attacking that at its root. And Faye is our Director for Inequalities around this whole issue. What's the title? Inequality. Health Equity and Social Justice, the first university in Britain with a Director for Health Equity and Social Justice. This is massively important to us. So I believe if you put enough effort into outreach to the community, if you put enough effort into confidence building in that community to take that step, and then if you put enough effort into training those practitioners, those clinicians, those medics, to be part of the community, reach out and connect, you can't go wrong for sustainability. And you have to overcome the fact that we all have to recognise that there's massive prejudice that needs to be overcome out there.
Okay. So it sounds to me like your organisation is trying to put the money, their money where their mouth is. So I think we should only go over to David, who is the Chief Executive Officer of the National Lottery Community Fund. So same question to you then, David. How much of a part does racism play, and what's your organisation doing to tackle that?
Yes, I think it's really good that we're using that word, because racism and injustice is really present in our society, and we shouldn't ever ignore that fact. For us as an organisation and sustainable change, for us, the real shift that was important over the last couple of years inside the National Lottery Community Fund was being confident about talking about equity rather than just equality. And everyone here in the room knows that. We're all, I think, it's been a theme right through today. And of course, equality is so important to ensure that there are open, accessible, fair standards. We have universal approaches inside public services, and we are a public service too as a National Lottery Community Fund. But when we were doing our strategy and when we were listening to people and talking about our own experience and people's experience of us as a funder, it demanded something more than a focus only on equality. And we looked across more than 400 government departments, agencies, public bodies. How many of those more than 400 organisations are talking about equity rather than just equality? We found one organisation, and that was NHS England, actually. And for us, when you then start to talk about equity, it enables us as an organisation to talk about inequity, to talk about what are the economic, the social, the environmental injustices and causes that are driving some of the things that we see in the observed outcomes across a whole range of fields, not just inside health. And then that demands of us to be much more scrutinous across our governance, across our funding, across who we are as an organisation, how we're involving people with lived, learned, practitioned experience to shape and drive the choices and things that matter to them inside their community. So that's why we say it starts with community. It starts with community. It's just, in a sense, sometimes these things are so simple, are so self-evidently true that the agency, the ideas for change lies inside communities. That's a shift for us as an organisation to work back from communities that we serve. If I could say anything to more public organisations who need to come into the room, would be to start having those really challenging conversations as an organisation, to start talking about equity, not just equality, and to then really be demanding of yourself and to hold yourself open to the accountability that will come from that.
All right. Lizzie, over to you then. Great to hear NHS England called out then. That's so I've got to be honest, I mean, 2023 was a really hard year on this, and Yvonne made a comment earlier in her presentation about the politics at the moment. And for those of us working in the NHS, working in this area, you know, sometimes when you work, particularly at this kind of level in the NHS or strategic level, you know, the way that the politics interferes with the work is really difficult to manage. And I think last year we had some really difficult challenges to overcome in that respect. And I'm sure a lot of people in the room will know the sorts of challenges that I'm talking about. I think it's a real testimony to people's personal leadership that you pick up and you go again and you go again and you go again. And it's easy for me to say that, being a white middle-class privileged woman who's been able to progress very well in my career without too many barriers in my way, you know, compared to a lot of my colleagues who have not had that experience. But I think there is some really meaningful work going on through NHS England and through the regions and through the systems and through providers and so on. And much of it, I mean, again, I refer again to the work that Yvonne supported us with in London 4 years ago now, where we launched a London workforce race strategy, a 10-year strategy to address racism, discrimination in the NHS London workforce in the NHS in London. And although we have not got London where it needs to be, London still fares really poorly in comparison to other regions. We're seeing sustained improvement against the majority of the indicators in our RES and other data sets, showing that this relentless focus and the energy of people who, against the odds, get up and go again, is making a difference. We've got an anti-racism statement that we've done through our London People Board that organisations are signing up to and people are making commitments to. We've got the NHS England EDI improvement strategy and high impact actions that every employer across the NHS is working towards and needs to be achieving against. And a big challenge to us in London last week about why are we measuring the life out of A&E targets at 76%, 3 calls every day, you know, why are we never using that approach to chase down these targets on EDI, and why don't we hold a mirror up more to ourselves to say if we really mean it in NHS England, if anybody knows NHS England, if we mean it, we measure it. You know, so there's a lot of challenges to take away from the whole conversation, but I think there are a lot. I think as an organisation and as the leadership in London and so on, the commitment is really very strong, and we are seeing some results of that, but being very honest about the fact that we are still just not where we need to be, and we are letting people down. I'm a workforce director, we're letting our people down with what's happening with industrial action, with what's happening on the back of COVID, the exhaustion that people have experienced, the lack of time to recuperate and recover from that, and the expectations on them. You know, it's a really difficult picture.
Thank you, Lizzie. Over to you, Kamna.
Thanks, Melissa. So as an organisation tackling health inequalities and trying to understand the drivers of health inequity, we absolutely recognise structural racism as a determinant of health. In our strategy, we are really clear about the fact that race equity is central to health equity. And some of the ways that we are able to operationalize that, I guess, is so recognizing that community organizations are the glue between the health service and communities. Co-funding, I think, is really important, multi-year co-funding. So Black-led organizations, community organizations aren't having to go through this kind of project cycle funding, trying to prove that they are having impact, that they can be trusted. I think that's really important. But also recognizing that for a lot of Black-led organizations and the people leading these organizations and the staff, the boundary between the professional and the personal is really blurred. They don't get to switch off. So the burden of, you know, that disproportionate impact on those lived experience leaders of these organizations has to be named. And one way we try to address that again is ring-fencing funding for staff well-being and not being prescriptive about what that should look like and what that should be spent on, because, you know, well-being means and looks very different for different people in communities. So, yeah.
No, thank you, Kamna. So I did that purposely, choosing to use the word racism, because I think that that's something that does get skirted past quite a bit. And I know that that's something that's very real and raw to Black Londoners, to Black people across the nation. They will speak openly about racism. I think it's rare that you find Black people talking about inequality and using those sorts of terms. But in terms of just on this topic of racism, I know you mentioned, Lizzie, that obviously you are measuring, you know, you're looking at the data, you're looking at whether these targets are being achieved. Do you think that there's a softball approach to doing this? Should there be more consequences when targets aren't met? Because obviously with inequality, whether that's in maternity care, we see death. Whether it's sickle cell, we see death. Whether, like you mentioned, mental health, we see death. And, you know, Black Londoners or Black people in general, their lives are valuable and their lives mean something. Should there be more of a sort of stricter, or should there be more consequences for this push, this effort for anti-racism to actually mean something?
Yeah, I think you're absolutely right, and we get that challenge a lot. What are the consequences if somebody doesn't do this? If you look at the scores, so we just recently got the NHS staff survey results that we get annually. You know, what are there consequences for organisations who are at the bottom? You know, how do we understand what an organisation at the top is doing and show at the bottom? I've been in a number of conversations about this where people feel that consequences are going to be difficult to implement and could have a negative impact where you're trying to build a movement. I wouldn't have a view one way or the other, but I think that it's absolutely right that we're asking that question. It's absolutely right that we should be holding to account organisations that aren't making progress, that we should be asking questions of leaders who are not, you know, boards that where this isn't on their agenda would be a good example. The high impact actions that are being rolled out from the improvement plan ask for everybody who's on a board to have measurable objectives around EDI. Well, if that's not happening, then, you know, there are questions that should be being asked, and that's what this work is all about. So I think things are moving in that direction, but it's really hard to think what the sanctions and consequences would be in a system like health. But I'd be interested to hear more from people who had ideas about that.
Yeah, I think when I've had other people talk about this in terms of consequences, maybe penalising, you know, organisations that aren't meeting those targets. But I also just want to bring up you might be aware of the recent report that the Women and Equalities Minister, Kemi Badenoch, brought out. And she said that, EDI is failing and that actually it's backfiring and it's performative and it's not working. Do you agree with those comments?
No. Because progress, as it's been said all afternoon, there is progress being made. If it was failing, would we be seeing that progress? And what we see in London is, we can attribute where progress is being made to certain interventions that have been deliberately put in place to try to tackle, for example, unfairness in the way that people are recruited. One of the stubborn issues in the staff survey and the res data that we're not seeing improvements enough on is the level of disciplinary action to people who, to non-white, colleagues who experience much higher levels of disciplinary action and so on. If we weren't doing that work, we didn't know that, wouldn't know those things. What I would say is it's not being made anything like fast enough, and there needs to be much more of a push and sort of investment in terms of people's time, how we measure, how we hold to account, how we adopt and spread good practice. But to say it's not working and it's failed, I couldn't agree with that statement.
Do you have any thoughts on that, George?
I try and avoid politics, but as a head of an institution, the university, you try and avoid politics. However, what I would say is the importance of role models. If you look at our last 4 student union presidents, 2 are from Nigeria. They're from an African continent, and they act as role models for students to get involved in changing the environment and changing justice. And I don't think, and I look at this panel, there aren't enough people as role models, in terms of the people you want to look to, and in that sense, we're really privileged in that we've got Clive Myrie as our pro-chancellor, as the ambassador. Now, Clive is a Bolton boy, he's actually grew up in Bolton, but he's our pro-chancellor, and he's there on your TV every night, and I love that moment when our students can identify with there's their pro-chancellor on the TV. They see him at graduation, they see him close up, he engages with them. There he is on national television. It's a great opportunity, I think, for people to think, yeah, I can do that, I can break through that area, and also we have to be really active in supporting people to do that. So, I'm a massive mentor of our SU presidents and the people involved in our SU SAB officers to get them out there changing community. So I don't know what's happening in NHS in the description you've given. I know politicians make a lot of noise about all sorts of things that I never entirely believe any of them, to be honest, but that's probably a non-political point. But in reality, what we're talking about is changing the lives of young people to become role models for communities for the future, and recognising that racism is big in Britain still. It's big and it has to be overcome. And only if you recognise that do you start to attack it and overcome it. And that's what's really important to us at our university.
Kamala, I can see you have something to say.
I always have something to say. Nothing in particular, except I absolutely don't think EDI initiatives are failing. I think they're really important, and particularly from a funding institution perspective, they've been really valuable in diversifying the funding workforce as well. And if we diversify the funding workforce, we're making better decisions for minoritized communities. If we have, representation matters, and it's important when we are working in partnership with community organizations, Black-led organizations, bi and for-led organizations, that they see people like them who understand the drivers that they're experiencing, the issues that they're experiencing. So that might be structural racism, but that might be lots of other things as well. And so I think EDI initiatives are really important. Are they enough? Probably not, because it's not just about getting Black and brown people or minoritized people into organizations or the workforce, but opportunities to grow, develop, and then really belonging and feeling that sense of belonging. So, yeah.
Thank you. Did you have anything to say?
Well, I guess my only observation would be, it sounds like we're at the start of a journey that needs a lot of redoubling of effort and action. If it is true that out of hundreds of public organisations, only a few are really using a focus on equity, and for us, we say that means we'll invest most where there's discrimination, disadvantage, and poverty. And discrimination is really what we're talking about here. That's got to drive a shift, right? That's got to drive a shift in the behaviour, in the culture, in the governance, in the funding, in what we measure and what we hold ourselves to account for. And we as an organisation will do that. We've historically, as a national lottery funder, used deprivation as an indicator, but that masks so much. And for us, the next stage of the journey is to break that down much more into some of the historical patterns, into discrimination as well as deprivation. And that will drive our own funding choices, and that'll be driven through our then governance and our day-to-day choices that we're making in our grant making. So that would be my response to it. I think whether you see that we're far along the journey or at the start of the journey, it points to me that we all need to be redoubling our efforts and to be holding ourselves accountable for the public and communities that we serve.
So overall, it seems like the panel feels that no, EDI isn't a waste of time. It is doing something. It is achieving something. I know some people feel that 2020 was a huge year for, diversity and inclusion initiatives after the murder of George Floyd by a white police officer. Do you feel that since then, since 2020, we're now in 2024, do you think things have slowed? And if so, why? And what needs to change? I'll give that to, I'm going to put you on the spot, Lizzie. I'm really sorry, but
I was hoping that you would. So that really took me back when you said that to that time or when that happened, and how raw that time was, and what an eye opener it was for us in organisations like the NHS to really start to understand how our people were feeling, and to try to respond to some of that anger and some of that hurt, and I think it was a turning point in people's sort of understanding of EDI and how it interacted with work and how people felt about their, the organisations they were with. But then, of course, quickly on the back of that came COVID, and I think that then accelerated that work even more, predominantly through the vaccination camp. Well, first of all, through the shocking realisation of how it was disproportionately affecting people, and Bola talked about that earlier. I won't repeat what she said, but it was very stark. But then through the vaccination campaign, when the predominantly white leadership, desperately trying to do, to do the right thing with the vaccine, had the awful realisation that a hell of a lot of people in the communities that they served didn't trust them and weren't going to have that vaccine, and it was the turning point for understanding about the real meaning and purpose for working through communities, working to understand local communities, the power of community organisations, and the need for that partnership working and collaboration and understanding each other and so on. So I wouldn't say it has slowed down, because I think that was the two things kind of followed on from each other and built momentum around through the anchor work that we do in London, now really understanding the need to work through neighbourhoods and communities in order to reduce health inequalities. And the way we're talking about health inequalities is so different. We've got a different level of understanding. Is it enough? Is it fast enough? Has it given us all of the results? No. But I don't think I could say it slowed down. I think we've got a lot more sophisticated in our understanding and thinking. But everything you learn and every step you take forward, you realise that there's just a whole load more, that you need to learn and understand in order to do the work that you need to do, and that's the journey.
Thank you. Kamna, do you share this view that it hasn't slowed and that it's just become more sophisticated?
It's really tricky, because my initial instinctive response was like, yes, of course it slowed down, because it feels like it has, because it is really, it's the urgency of it is really real to so many people. But equally, I guess I agree with Lizzie in that there is progress. It's not at the pace that I would like it to be, but we're all here today. We're at the first Black Health Inequality Summit. We're talking about the issues quite differently. But I think potentially it feels like it slowed down also because there is discomfort in talking about the issues. We don't have the language as a society to talk about structural racism in a way that is I don't know what, but nuanced enough. So it feels like it has slowed down, and it probably has slowed down. That urgency and kind of impetus that we had in 2020, 2021 is definitely missing. But I'm conscious that progress is probably, there's progress, there's not change, but baby steps. It's not, yeah.
I feel like the audience is quite passionate about this one. Would anyone like to, should we just go to questions? Pardon?
We run out of time.
Oh, we run out. Oh, that's a shame. I'm so sorry.
Sorry, guys. Can we put our hands together for the panel?
I think many of you would prefer to speak to them one-on-one after. So, you sure? You know, mixed bag, 50-50. So let's, yeah. Can we celebrate them whilst they take their seats? Thank you. They're going to hang around for a bit, so when we close, you have some conversation. Please, just give me 5. I told you we're going to do some magic, so give me about 5 minutes or so if you want me to still keep my job. Talking about role models, the person I'm going to introduce next to, you know, share a few thoughts and reflections. He's an amazing man. He gave me words of counsel many, many years ago when I joined Street Pastors, but some of you may not know, but he preached in Parliament and he spoke about integrity. And unfortunately, that brought down the last government with series of resignations. Reverend Les Isaac, put your hands together.
Well, good afternoon, everyone. Let's try that again. Good afternoon, everyone. I suppose some of you, many of you wanted to continue that discussion. It was getting good, wasn't it? But let's hope and pray that these guys organize something for next year and give us more time. I'm here just to give us a word of encouragement. Over the last couple of months, I've been talking to some young people, and we were talking about hope. And I said to them, listen, I would have never imagined the Berlin Wall coming down. Before the Berlin Wall and Checkpoint Charlie, I was going to Berlin and I was having committee meeting and planning conference in Berlin. And all of a sudden, I saw on my TV people climbing the wall, people picking at the wall. And by the time I went back to Berlin the following year, the wall was completely demolished. I was there in Berlin on the reunification night and at the Brandenburg Gate, and I thought, wow, I'm seeing history, I'm part of history. I suppose that some of us would never imagine that apartheid would end in South Africa and Nelson Mandela would be released and become its first black president. But we saw it. We saw it. We saw it. I suppose that many of you or many of us would never imagine seeing a black president in the United States of America in our lifetime. Yet we saw it. And I want to remind us that we need to be people of hope. The confidence that something good is going to happen. We are not to leave here feeling depressed or anxious, but we need to leave here with hope, saying something good is going to happen. There's a text in the Bible, and it says, without a vision, the people perish, or cast off restraint. They all do their own thing. If we are going to survive, we need clarity in terms of a vision. Over the last 3 years, Dr. Jackie McLeod and myself has led a team of professional doctors and academics and business people looking at the state of the African and Caribbean community. What would it look like over the next 10 to 30 years' time? Because I don't want to just think short term. I want to think long distance. Because it means that if we're going to think long distance, we've got to put things in place that our children and our grandchildren, maybe we will not accomplish it, but they will. Vision is about the long term. I'm grateful for Dr. Chichi Ekator, who have a GP but says, I need to do something more than my GP work. I need to roll my sleeves up, and I need to get into my community, and I need to be part of the solution. speaking to a friend of mine, an ambassador. We were just talking and having a meal, and she was relating to me that the fact that they had an ambassador meeting, a global ambassador meeting, and they were eating together and they were talking. One ambassador talked about, well, my country's 10-year vision. Another ambassador talked about 15-year vision and 20-year, and they were getting excited. Until later on, a Chinese ambassador stood up and said, well, my government is thinking they have a 900-year vision. 900-year vision. So you can imagine how everybody felt. It's important for us to have a vision. We've been working in Lambeth Council. I want to congratulate them, Jim Dixon and his team, for their vision. They've got something. They're pushing for something. They want to accomplish something. And if we are going to accomplish something, then we need to be passionate about it. Listen to what Steve Jobs says, and I like this. If you're working on something excited, something that you're excited about and really care about, you don't have to be pushed. The vision pulls you. The vision pulls you. Even when you don't have money, even when things are not working, the vision will pull you. It's important. Listen to what a blind woman says. A woman called Helen Keller, she says this. She's blind, born blind, you know, with disability. There wasn't all these policies about disability before. But hear what she says. The only thing worse than being blind is having sight with no vision. Companies, whether it's public health, NHS, local authorities, the national lottery, you may have money, you may have power, but without a vision, your organization will fail to live up to what it exists for. If, when you're a practitioner, you need to understand, you need to get the vision clear. One part of the Bible says, write it down. Make it clear. Because there's some part of our vision that we will not accomplish. I am working that my grandchildren will accomplish what I've started. We need to be optimistic. We need to see the future. I often tell people that when Jesus came on this earth, he didn't have a 10 or 900 years vision. He had 1,000-year eternal vision. Because he knows that at his heart is people. And that vision starts with all of us. We're all doing something. We're all complementing. We're all standing on each other's shoulders. We all recognize that we don't have it all. But we recognize that collaboration and synergy works. Hear what it says. 1 chase 1,000. 2 put 10,000 to flight. We need to learn to understand that together we will accomplish far more. Sometimes we need to lay down some of the things that we have and join something bigger, because we'll push faster and we'll have greater impact. So I want to encourage us. Look ahead. Look ahead and see what only you could accomplish, but you could accomplish it with someone else. And as we do that, we will be able to push down this wall of inequalities much quicker, much faster than we could ever imagine. Let's leave here excited. Let's leave here knowing that we've made friends. I'm not the only one doing something good. Let's leave here saying there are people out there who are doing something good. I'm going to join with them, and we're going to push together. We're going to work together. We're going to encourage each other. We're going to encourage each other. If we're religious, we're going to pray for each other. Doesn't matter whether you're Muslims or Hindu or Christian, but we're going to pray for each other. Why? Because we are doing something good that's going to benefit not only our community, but society. Is that okay? Now, you don't have to be a Christian to say amen. Amen says, I agree. Thank you.
Wow. Thank you, Reverend Les Isaac. You are always on point. Brilliant. So I just want to thank you all. You've been a fantastic audience. I can't tell you how, anxious some of my team members were. but you made a real difference because you're still here, you're still standing. But massive thanks. So please put your hands together for yourselves. Thank you. I just want to encourage you to follow London Inspire. You know, like Reverend Les said, we've got to spread the word. This is long term. You know, so follow London Inspire. Social media bars are down there. Go on the website. It's meant to be a resource hub. This is all about collaboration. No one can go alone. And that is why I'm absolutely delighted we have funders in the room, and we told them, let's start a conversation about how we invest for the long term. So I'm really grateful they're here. So visit, you know, Inspire, follow us on social, those of you who are there, spread the word. Saturday mornings, the health webinars still continue. And following, you know, Khan as well, please scan the QR codes, put someone forward. Also, you know, we couldn't have done today without our guest speakers. Can we put our hands together for them? Right from morning, they have given up time. You know, all of them, they've been working up there, coming down, mingling, going back up. You know, it's just incredible. And for me, that's what drives me. So thank you all to our keynote speakers, to all those workshop facilitators, contributors, thank you. Our compare Nick, you know, yes, we've been chatting on Twitter, and it's the first time we've actually seen each other. So thanks, and thanks to Melissa as well. She's had to go because I didn't know she had a new baby. But she left the baby to come and facilitate this session. You know, so can we celebrate them? The volunteers that have done amazing work, welcoming you, making you feel at ease. Please, let's celebrate them. And to the program funders, NHS England, London, you know, Health Equity Partnership, the LEP. But then Leonora, you were here, you gave your thoughts and reflections, and you so inspired, you want to do more. So I'm conscious, I don't have the check now, but the program will continue. So thank you, Leonora, you know, for that. And also to our partners, you know, for the summit. When we chose this place, I didn't know the cost was going to go through the roof. But the National Lottery Community Fund, Shane Ryan, David Nord, Sarah Watson, Lillian, and also Impact on Urban Health. I met with Peter. Peter is actually on paternity leave. That's why he's not here. But Kamna, Antonia, and many other colleagues, you've been doing brilliant work. But also, one of the things they did was to bring along some of those they funded so that we can work together, as was said. Now, for those who may not know, London Inspire program has a steering group, and it's the members that make a difference. And the steering group is so critical because we didn't want it to feel like Khan has been parachuted in, although we have working relationship in a couple of boroughs. So please, let's appreciate the steering group members. If you're here, can you stand? Steering group members, some of them were welcoming you this morning. Reverend Les is the steering group. Alberta. Yes. Sister Cheryl, they all took some time off. So thank you. And also as part of the steering group, we have some stakeholder, you know, partners, Asha and Lamide, you've been supportive as well. So please, we love you so much. We even exchanged your names. And then finally, you know, to our Khan staff, you know, the delivery team. We've been down in London since Friday evening, trying to rehearse, trying to work through things. You know, we even pulled off an event in Tottenham on Saturday, doing health checks, and there were nurses who came in less than 24 hours to meet with the community. So all the Khan staff you met at the decks, thanks. You know, can we appreciate them? And then whilst I think I've forgotten them and they may get me out of job. So the final, but certainly not the least and very, very important, are two amazing co-chairs. The leadership they've shown, their passion, their commitment. Can you come up stage, Juliet and Sedi? And Sadie, that's for your wife. Brilliant. So extremely grateful for all your time once again. We're going to hear from these two amazing people, before we leave. But, massive thanks, and, all those who have pulled things off. Our chair, she works incredibly hard. Percy, all the team. So thank you. Over to you, our wonderful co-chairs.
Okay, wow. It feels like it's been an amazing day. I think what's also amazing, Faye and I was saying, is that it is 4:30 and we're still all here, which is pretty amazing because it's been a long day. Just echoing Charles's thanks to everybody. I think there's some things that I'm going to really take away, and I hope you do too. I think Kevin's kind of, better, so do better. So what are we going to do better, and what are we going to do to change the status quo and the current inequalities? So I think for me, that's a really big message. I think Reverend Les, the hope message, I think there's nothing without hope, so I think that's really important. And I just hope that you're able to take all that you've learnt today back to your networks and really look at what are you going to do differently? How are you going to change things? And who are you going to share this with to make a bigger impact? I don't want to ever hear someone say hard to reach communities again. I find it really frustrating. I hope you're able to challenge that in the spaces that you're in, and you're able to really kind of look at what can you do differently to have an impact. So I hope you've had a good day. I hope you've learnt lots, but I hope you've had some fun too, because I think that's really important. So yeah, thank you. I'm going to hand over to my co-chair.
Thank you very much. I'm very, very rarely lost for words. But on this occasion, I am genuinely lost for words. What we've done today, collectively, I think, has started something. The challenge now is to maintain that. I'm a great one for little sayings, and one I share as often as I can. There are no shortcuts to anywhere worth going. So this is not about, I said this morning, it's not about today, it's not about this week, it's about the future. I've got 4 grandchildren. I want this world to be better for them than the world I came to as a son of Windrush many, many years ago. I think we can do it, actually.
Yes, we can.
Let's be clear, there are headwinds that we are battling against. But I've got this gut feeling the headwinds are going to shift sometime later this year.
There's hope.
Don't ask me why. I don't know. I haven't got a crystal ball. But I think what I've been a part of, previously with LEP and with Inspire, is a real shift. So please leave here today feeling really positive. Really, really positive. Because when you go back and they say, oh, what was it like? You have many, many messages to share with people. And as I often say, the answer is leadership. Now what's the question? Have a good evening. Thank you very, very much.
Where's your flowers? Give me flowers.
How am I going to get them home? I'm going to get here to the House of Commons. Well, probably a taxi for that.